All right, committee, welcome back. We ran a little bit over because we got to the hospital a bit late, but let me publicly thank Star Valley Medical Center for the wonderful lunch and tour and placing there's six in the country in critical access hospitals right here in Wyoming. So pretty impressive. So you'll remember from our interim topics committee, there is just kind of a catch-all after management council of about 8 different topics that we discussed, and several of you had voted on a couple of them, and they all kind of fell into this pharmacology category. And so really for the next hour or two, we're going to kind of do a cursory overview of all of the issues in that area, and then we can debate if we want any bill drafts and what we may want to pursue when it comes to those topics. So because the Department of Health is here, it seems most, I guess, appropriate to have them do kind of an overview of the topics listed. And then I do understand, Director, we actually have agency updates for the department, because I know there are some questions on this side of the table of some things that are going on in the health department. Maybe we will save those for tomorrow with agency updates and just focus on the pharmacology topics at hand. So welcome, Director Johansson, floor is yours.
Thank you, Mr. Chairman, members of the committee, Stephen Johansson with the Wyoming Department of Health. Like you mentioned, Mr. Chairman, on the agenda, somewhat of a catch-all topic when it comes to pharmacology. I know there's several issues the committee was interested in learning about, hearing about, or hearing updates on. Accordingly, we can go as detailed or as quick overview as you would like. On the Medicaid side of pharmacology issues, we prepared some reference materials that you should have in your committee materials, kind of an omnibus presentation from the Department of Health, starting with Medicaid pharmacology on step therapy, moving to Medicaid pharmacology policy, various issues related to opioids, and last but not least, since it is kind of a hot and pressing topic, Medicaid policy, reimbursement, et cetera, on various weight loss drugs, which have become quite popular around the country in recent months. Mr. Chairman, happy to do an overview on all of those, answer questions if you would like. I'm joined to my right by our state Medicaid agent, Lee Grossman. We also have Corey Cooper, who most of you are familiar with, who heads up our Medicaid pharmacy office. She is available on Zoom should anybody have any questions. But Mr. Chairman, committee discretion, happy to take direction.
Maybe perhaps committee will just call it a Medicaid update, because I think all the topics in your presentation deal with how Medicaid interacts with these areas. And then I know there are specifics on each of those areas that we have people here to talk about. So maybe we'll do the health department agency update tomorrow, and this will just be the Medicaid update on pharmacology issues that we're dealing with. And you can kick us off in a in an unbiased and overview manner of what Medicaid does in regards to all these issues. So with that, Mr. Grossman, the floor is yours. Do you have anything further, Director? No.
Mr. Chairman, no. I think for the purposes of this presentation, if we could bring Corey Cooper in on the Zoom, given that there's lots of detail here about Medicaid pharmacology, but we could, like I said, we can be quick, but please feel free, committee members, interrupt us, ask questions. We weren't exactly sure what the intent was on some of these, but tried to give you as much information as possible. So with that, Corey Cooper, if she's available, if we could call her in.
Dr. Cooper is online. I can see her in my screen. Is she giving the presentation or Mr. Grossman? She is. All right, Dr. Cooper, welcome. The floor is yours. Proceed when you're ready.
All right. Good afternoon, Mr. Chairman, members of the committee. I'm Corey Cooper. I'm the Pharmacy Program Manager for Wyoming Medicaid. I'm happy to join this afternoon and just give you a very high-level overview on a couple of topics here as we discussed. So the first one is step therapy. Again, very high level, a definition of step therapy. This isn't, you're not going to find this published anywhere other than this slide because it's out of my head, but basically it's requiring a trial and failure of one treatment before advancing to a different treatment for the same disease state. So basically try and fail one treatment before moving on to something else. Some examples here, just to sort of put it in context, would be knee pain. If you go to an orthopedist for generalized knee pain, meaning you haven't had an injury or something that would lead to a specific type of treatment, you might be asked to do some physical therapy and simple analgesics, ibuprofen, acetaminophen, that type of thing first. And if there's no relief from that, they might move on to injections into the joint for an osteoarthritis in the knee. That's a little more intensive. And then if those stop working or aren't effective, it might be recommended that you would have knee surgery to replace the joint or clean up the joint space or something like that. Another example, more pharmacologic example, would be for atopic dermatitis, which is a form of eczema, a dermatology issue. So we might start with that, with a topical corticosteroid. If that is not getting good response, might move on to a topical immunomodulator. And then still not adequate response to that, we might move on to an injectable immunomodulator. So if we go to the next slide, we can sort of apply those examples to why step therapy might be required. So early steps in step therapy, so what you saw there for number one in both cases, they tend to be more conservative, less invasive, or have fewer side effects and lower risks. So in the second example, obviously something topical is going to have be less invasive than something injectable. Physical therapy, very conservative, and not putting any chemical in your body at all. So that would be less invasive and more conservative. It might have a more robust clinical evidence of effectiveness or clear evidence of clinical superiority. So those would be the early steps. If there's obvious clinical evidence that something is superior, that would be reasonable to try first before moving on to something that doesn't have as much evidence to support it. And they might be a less costly choice in a category where safety and efficacy are essentially equal among all treatment choices. There's a caveat to that, or a few things to think about there in the next slide, so we'll get there. Another thing to note is that, oh, I'm sorry, go back one slide so I can address the late step drugs. Sometimes, thank you, sometimes late step drugs, or sometimes drugs in general, become later steps in the treatment course simply because they actually are labeled by the FDA. The studies support them being used later in a treatment course because of evidence that was collected during trials, that their place in therapy is actually after other things have been tried. So for example, there are a few antidepressants on the market that are actually labeled as being used for treatment-resistant depression, which the implication obviously is that there has been other treatment tried, or chemotherapy agents that specifically state that they're for patients previously treated with other chemotherapy agents. So in the chemotherapy space, we sometimes get into third and fourth line treatments, and that's simply because they're labeled that way. And that's what they have evidence for. All right, moving on to the next slide. Thank you. So the step therapy, the Medicaid policy for step therapy is that in Medicaid, the cost of the drug is considered a factor in determining a place in step therapy if there is no evidence of a safety or efficacy difference between it and competitors in the same drug class. So what this means is we in Medicaid pharmacy have a pharmacy and therapeutics committee that contains 6 practicing pharmacists from around the state of Wyoming, 5 practicing physicians, and an allied health professional. They're given clinical information on new drugs as they come out. We discuss them as a committee, and the committee votes whether they feel that there is significant safety or efficacy data between the new drug and the drugs existing in the class. If their vote or their recommendation is that there is no difference in terms of safety and therapeutic efficacy, then that moves to the state to make the decision based on cost. But the Pharmacy and Therapeutics Committee is not given cost data when they're making their determination about how they would like to recommend that drug be covered, first line, second line, et cetera. A couple caveats that I alluded to it is very uncommon for drug manufacturers to conduct head-to-head trials between their drug and competing drugs. So when we're talking about therapeutic efficacy of drugs and how a particular drug sort of stacks up to the competition, we're typically looking at studies where each drug is tested against a placebo, rather than the two competing drugs being tested against each other. The relative safety and efficacy then is inferred based on the quantity and quality of clinical evidence, because of the lack of head-to-head data. And a single drug may be labeled for multiple indications, but may only have superiority evidence for one indication and not be considered superior to other drugs in the class for other indications. So we could have a drug that was step 1 for one indication and step 3 for another indication, for example. So there's that. And next slide, please. And I'm not sure how the committee wants to do this. I can move on and do my whole spiel, move on to opioids, or stand for questions on the step therapy portion.
Throughout the afternoon, so not seeing any immediate questions. Dr. Cooper, you can continue on opioids.
All right. So on the topic of opioids, we'll go ahead and get into these slides. This is really an overview of Medicaid policy on opioid drug coverage. So for opioid naive patients and acute pain patients, being consistent with Wyoming law, opioid naive patients can get no more than 7-day initial supply of opioid medication. And for acute pain, which is defined in the literature as less than 6 weeks of continuous opioid therapy, we don't have dosage limits on those after the first 7 days. And there's no dosage limits in the first 7 days, but then during that acute phase, we're not as concerned about the morphine equivalent limits that you're getting. Typically acute pain that isn't going to go on to become chronic pain. We're talking about maybe post-operative pain or pain caused by an accident or that type of thing. All right, next slide. And then we move into patients with chronic pain, which obviously would be defined as more than 6 weeks of continuous opioid therapy. Our coverage limits there are 120 morphine milligram equivalents per day of long-acting opioids. So obviously all opioids have a different potency. So the way that we sort of compare the potency of all the various opioids is to bring them all back, do a calculation to bring them into morphine milligram equivalents. So our coverage limit right now is 120 MMEs per day of long-acting opioid. We are moving toward a 90 MME per day limit at the recommendation of our P&T committee and also CDC recommendations. We will cover, along with the long-acting opioids, we'll cover 4 units, meaning 4 tablets or capsules per day of short-acting opioid meant for breakthrough pain. So if the long-acting opioid isn't holding the patient through 12 hours, that type of thing, they could have a short-acting opioid for that. We prohibit the use of more than one long-acting or more than one short-acting opioid concurrently. So we'll do a long and a short. We can cover a long and a short-acting together, but we cannot cover 2 long-actings or 2 short-actings together. And we do not cover an opioid with a benzodiazepine concurrently because there are increased risks involved with that. So next slide.
If you can hear me.
Oh, now I can.
I'll take. Oh, good. So when you say these on the milligram equivalents, that's just what you reimburse for. So they could still be prescribed above and beyond that, but Medicaid would only reimburse for that amount. And do all of our pharmacists clearly know that throughout the state?
Mr. Chairman, yes, and yes. So we're not putting limits on what can be prescribed. We are only putting limits on what we will reimburse the pharmacy for. And yes, this information has been shared with pharmacies multiple times through newsletters and then individual communications when we get claims that exceed these limits. So prescribers also are aware of the limits.
Thank you.
All right.
Perfect. Please proceed.
Okay. And then also in the area of opioid, we wanted to be sure that we touched on the fact that we do cover, I'm sort of skipping to the last bullet, but Medicaid covers drugs used in the treatment of opioid use disorder, medication-assisted therapy, or the more, I guess, recent term is MOUD, medication, opioid use disorder. So, and then getting back to your question, Mr. Chairman, just a moment ago, if a Medicaid client pays cash for any prescription, so we don't actually see the claim in Medicaid, and we're not aware of it, we can't use it in calculating coverage metrics. So that would apply both to your question, like as in we don't stop the what is prescribed. If a patient wants to pay cash for it, they're welcome to do that. And we don't see the claim, so we don't know how long a patient has been using it or how much they are receiving. So next slide. All right, unless I hear otherwise, we're going to move on and talk briefly about weight loss drugs or weight maintenance drugs.
Thanks.
All right, hearing nothing, we'll go ahead and go to the next slide. So what are weight loss or weight maintenance drugs? The ones that are in the news right now, Ozempic, Wegovy, Mounjaro.
Good to go.
Okay, great. Are not the only weight loss drugs on the market. Certainly there have been other types of weight management agents on the market before this, not with the amount of uptake or success rates that we see with these drugs. So I really focused my discussion here just on these drugs. These all are medications that fall into the class of glucagon-like peptide 1 or GLP-1 drugs. There's a couple different agents on the market, and it's important to make a distinction between how they're labeled. So the generic of one of them is semaglutide. This is labeled with the brand name Ozempic for diabetes, to treat diabetes, and the brand name Wegovy that is actually labeled for weight management. The other agent is tirzepatide. Brand name Mounjaro is labeled for diabetes treatment, and Zepbound is for weight management. The mechanism of action of both agents, they work for diabetes by stimulating the secretion of insulin and helping keep blood sugars stable in the patient taking them. And they work for weight loss by suppressing appetite and by slowing movement of the food from the stomach to the small intestines, so patients feel full longer and don't actually desire to eat nearly as much. Obviously, there's a lot of use of Ozempic that's labeled for diabetes. It's being given to patients for weight loss, but in terms of what they're actually labeled for, this is where we're at. All right, next slide. Medicaid coverage policy, we do cover Ozempic and Mounjaro for patients with diagnosed diabetes after applicable step therapy has been tried. So we've come full circle back to step therapy. And we do not currently cover any drugs solely for the diagnosis of obesity or overweight. So therefore, we don't cover Wegovy or Zepbound at all, because that is all they are labeled for. And we do not cover Ozempic or Mounjaro for patients who do not have a diagnosis of diabetes, because that is what they are labeled for. So that conversation gets a little bit in the weeds. Happy to take questions. I believe that's my last slide.
So when it comes to the weight loss drugs, I mean, your area when it comes to those, what, semaglutides?
Yep.
No, the overall question, is there anything else we need to be working on or legislating when it comes to your area, when it comes to these medications? Or do you, the current process is working or evolving quick enough that we can just sit back and wait? Or do you have any kind of specifics on things that other states are doing in this area that we could also be doing?
Mr. Chairman, I don't believe that there is a need for, we'll say, legislative intervention at this point. I am aware of a number of states who have chosen to cover weight management drugs for weight management for their Medicaid populations, and there are a number of states who have not. Obviously, there is a financial burden attached with making that coverage decision. We're analyzing that. And we're certainly looking at it because there is a demand for it. And obviously, there are medical conditions that are greatly improved with the use or with weight loss and better weight management. So we are taking a look at it, but at this point, I do not believe that there is any need for the legislature to draft legislation around this.
Representative Yin.
Thank you, Mr. Chairman. Ms. Cooper, have there been any, and maybe some of the other states that have chosen to enact or to cover these drugs, have there been actuarial analysis on cost savings from reduced morbidity or reduced incidence of diseases that are co-indicated with weight gain?
Mr. Chairman, Representative Yin, unfortunately, we're at a point in these therapies where they have not been on the market long enough to probably see a great deal of cost savings on the side of, so here's a patient who has lost weight and better manage their other health conditions, and so that we can calculate a cost savings. There is no state that I'm aware of that has been able to show a cost savings because they just haven't had patients on these medications long enough to have avoided some of the comorbidities that go along with being obese or overweight.
Representative Clouston.
Thank you, Mr. Chairman. Dr. Cooper, just wondering, does Medicaid in Wyoming cover other programs such as smoking cessation or alcohol abuse or drug addiction problems?
Dr. Cooper.
Mr. Chairman, Representative Clouston, we do cover agents that are for, as I, let's see, one topic backwards. We do cover medication-assisted therapy for opioid use disorder. We do cover medications that are used for alcohol abuse to help deter patients from that. And we do, I'm sorry, I lost the very first thing you asked about. But I know the answer is yes. And the reason for
Smoking
that,
cessation.
so smoking cessation, yes, we do. The reason for that, and it's a little bit tricky, is in the federal law, Medicaid agencies nationwide have been previously prohibited from covering medications for weight management, or for anorexic drugs. And that these drugs in particular, but a little bit earlier with some of the drugs I mentioned that came to market before this, have sort of changed the conversation about weight management in the medical space overall to an issue of medical necessity or the medical benefits of weight loss versus the cosmetic benefits of weight loss. And so CMS has become more flexible with states' abilities to cover these medications under the Medicaid benefit. And so some states have taken advantage of that. We are just not at a point where we've done enough analysis to know what the, to do a good estimate of what the financial impact will be to the Medicaid agency in our budget, but we're certainly looking at it.
Mr. Chairman,
Or, yes, Director.
if I can add to that, Representative Clouston, obviously this overview is regarding Medicaid in terms of smoking cessation, substance abuse disorder, other types of treatments in and outside of the Medicaid program, state.
Questions for Dr. Cooper, Mr. Grossman, or Director Johansson on Medicaid topics just presented? Seeing none. Thank you for being with us today, Dr. Cooper. You're welcome to stick around, but we'll let you off the hot seat.
Mr. Chairman,
Representative Penn.
would this be an appropriate time to ask the Health Department questions on a different matter?
I know you have agency updates, but we have, while he's up here, let's throw questions at him. Go ahead.
Thank you, Mr. Chairman, Director. So let me see. I just wanted to ask a couple of questions. I know that there's been myself and other legislators have had a lot of outreach, and I'm sure you have as well, regarding some of the grants to the the communicable disease unit that were given. And I just want an opportunity to ask a few questions on that. I understand that those are federal grants. How many of those grants are given out, and how many were rejected?
Director Johansson, if you know.
Mr. Chairman, Representative Penn, I might have to get back with you in a few minutes after looking up those numbers. The details of those grants, you're right, they're through our communicable disease unit, federal grants for HIV and AIDS treatment and prevention, as well as other STDs or STIs, I think is the preferred term. Those grants are available from anywhere from $100 to, I believe, $1,499, given out to various entities that do disease prevention, disease treatment, promotion, those types of things. But I'd have to get back with you on the exact number of what's been given out in this most recent round.
Is there a rough estimate per year, or?
Again, Mr. Chairman, I can get that detail in 10 minutes. I just don't have it in front of me.
Follow-up questions. Go ahead, Representative Penn.
Please, Mr. Chairman. So I was shared the applications that were given to the Wyoming AIDS Assistance Program for the drag show bingo that was held in Laramie just a few days ago. On there that it says that their purpose was for education, training, prevention, supply distribution, and that it would be a testing event, and their focus population included, among others, youth and young adults. And then it was stated that they received two different grants, if I'm correct. The maximum amount $1,499, so basically $3,000 in grant money, which they spent on rental of the ballroom, advertising, $180,000, and yet are still applying for these taxpayer grants. On paper, they focus this as being a prevention directed event. But the advertisements and things that were put out to the community seems to point otherwise. Their exact words, that this is R-rated and not for children. Salty language, dirty jokes, and booze aplenty. That it was going to be a raunchy event. And so I guess reality is a little bit different from what the on paper intent appeared to be. Is there any way that these funds can be revoked?
Director.
Mr.
if you know.
Chairman, Representative Penn, it's a fair question. These funds work on a reimbursement basis, so they have not been allocated yet. The way that this works is, I believe the event recently took place, if I'm not mistaken. And they will submit, reimbursement for the grants that were approved for the allowable costs. Anything that was not allowable per the grant parameters would be rejected. I'm so happy to follow up on what is or is not ultimately approved. Their original application approval, not reimbursement, but application approval, was for the items that you mentioned. One clarification with this event, and again, I hope I'm not mistaken. I could be, and happy to correct that. The grant parameters include targeted prevention and treatment for youth and adolescents, but I don't believe this event was for that. Again, if I'm mistaken there, happy to correct that in the future. But again, the grants work on a reimbursement basis, and I would assume we would see that shortly. But to be clear, and I know this is caused some concern, and I've spoken with many of you about our purpose in these types of community events. It's not something we put on. It's not something that we organized, but with populations that we're trying to help, with our charge to prevent disease, and then when those diseases are there, to mitigate spread or refer to programs that are set up either by the health department or locally. There is, I believe, a role there. We take an agnostic and even an absent position on cultural issues or behavior of organizations or community groups that put these events on. But when there's a disease prevention potential, and there's a role for supporting either Department of Health provided or.
And it seems a little bit discombobulated to me when on paper they say this is our intent, but then the event is advertised as, alcohol is going to be present. On HIV.gov, it lists what the risk factors are for contracting and spreading HIV, one of which is influence of drugs and alcohol. And so we have an event that says that this is focused on prevention, and yet we know that the event is also in a way promoting these types of behaviors. You say that you're agnostic on the issue, but we're using taxpayer dollars, and I don't think that taxpayers are agnostic on this. And so it seems like I would at least hope that we would have a way to have a little more scruples in the way that these disbursements are offered, and let people understand that there's a possibility that you may not get these if it's a reimbursement. This may not happen if the event doesn't seem to meet a standard. I don't think that that's the wrong use of taxpayer dollars. I think we should have specific standards in place if we're spending other people's money. Would you agree?
Mr. Chairman, Representative Penn, totally agree with the top-down scrutiny from this body and executive branch on appropriate use of taxpayer dollars, whether federal or state. And again, we'll review the allowable expenses from this particular event that received grant dollars and make sure that it's above board. I've tried to be transparent with what our role wasn't and what it was. And if there's legislative interest in changing that going forward, I'm at the table for that discussion. Again, it's a tricky balance. There's people and communities who can benefit from support that we offer, and it sometimes in this balance gets uncomfortable. I understand that, but more than happy to engage in those discussions.
Senator Hutchins, do you have a question?
Representative Penn kind of alluded to one of my questions. And I hope when you provide us with information, you can also help us see how this money is to be used. Because drag queen show with what we saw there on the newspaper didn't look very good. How the money is to be used, a response was given to me that it's federal money, but federal money is our money. And then even if you get it in one pocket from the federal government, it's coming out of the state pocket to give to this group and out of the other pocket, saying, oh, it's only from them, so it doesn't really matter. Because I think it did. A lot of people were concerned, and I thank you for your response.
Mr. Chairman, Senator Hutchings, thank you for that comment. I agree. Again, before any public records requests were made, I was trying to share that information, so there didn't need to be a bureaucratic process. It's not something that we're trying to hide of what was and what was not provided by those grants. But again, going back to the delicate balance, our provision of certain substance use treatments, does that reinforce the behavior of substance use? I don't know. There's tricky questions here. But at the end of the day, when communities in events like this or many others, public health offices that put on testing events, things of that nature, there's a role for your health department there, and we'll be as transparent as absolutely possible with how those dollars come in. I agree with you 100% that whether they're federal funds or not shouldn't be an excuse of, well, these were federal funds. Don't look at that. Don't see if that's appropriate. That's absolutely your role, and we have many scrutinizers in that way, including the federal government. I mean, the reason we have the details out there is because there's subrecipient monitoring on even these small $1,400 grants that we have to report on. So more than happy to provide that level of detail.
Senator Bouchard.
Thank you, Mr. Chairman. So this goes beyond the scrutiny of the committee. As earlier, we were talking about the experts in the room. I mean, you are one of the experts in the room. I'm looking at a publication here, the Atlantic Study of the Day, drinking alcohol fuels the desire for unsafe sex. New research shows that liquor consumption affects a person's intention to have unprotected sex, one of the leading causes of HIV infection. So here we are doling out money to someone who says, hey, come over and get drunk with us and let's have some raunchy talk and some jokes. I mean, this lies on you, sir. So, I mean, that's where I'm at. So I'll leave it at that.
Then again, comments or questions to the director?
I mean, I think if the director wants to respond, I would be happy to defer to that first before I ask, but you called on me, so I will ask my question.
Sure, go ahead.
Director, so it sounds like, I mean, at least from two of the committee members, that there's a desire to not have prevention for high school grants. So grants for high schoolers to go to college and college scholarship grants. And so at that event, there's alcohol served. We do it at the Cowboy Bar. If we applied for a fundraising for the CDU funds to have a testing event at that event, do you think it would be inappropriate or appropriate for us to have that there with alcohols being served?
Mr. Chairman, Representative Yen, the risk of going down a rabbit hole of many hypotheticals, we don't have policies in our prevention funding or these grants that prohibit what a community organization or at an event does. It's just not micromanaged that way. But the point from Senator Bouchard is well taken. Learning of this and being listed incorrectly on this event as a sponsor, which I think gave the wrong impression that the Department of Health was putting it on. But in full transparency, funding did go towards this event. The point's well taken that should we review policies related to alcohol consumption. We will. I can't tell you a different decision will be made. I'm not sure that's our role, but we will look into that. So I'll leave it at that. Thank you.
So Director, would it be possible, and then I know Representative Ward has a question too, to get a list for our next meeting, just of all the grant recipients and maybe amounts for this committee?
Mr. Chairman, we could provide that long in advance of your next meeting, in addition to the information I mentioned earlier.
I mean, I auctioneer at least 2 events a month that have alcohol that are for charities and good causes. And I know over the last 20 years that the Department of Health gives money. You get listed incorrectly on a lot of things, from local plays in my town to anytime you give money as an awardee, somehow you're listed as one of the 10 sponsors. And we've certainly had this talk over the past decade, even before your tenure, that maybe there needs to be some type of stipulation when you give out a grant saying, please do not advertise an agency as putting this on. And I don't think they do it on purpose. They just, somebody's not, whoever gets the money is not the person designing the flyer. It's not but I would encourage you to look at
Mr. Chairman,
language.
Going back to last year, we did that for that purpose. I think this was maybe something that needs to be reinforced. Our logo, our name, again, without permission, unless we're putting an event on, or one of our offices locally is putting an event on, then obviously we make.
Thank you, Mr. Chairman. I just want to make sure the public understands what we're talking about here. My constituents and the public are very upset that what appears to have happened is that taxpayer dollars went to pay for a drag show. So certainly you would agree that that's inappropriate, correct?
Mr. Chairman, Representative Ward, yes, as stated, but what I would disagree with is that there were disease prevention and resource and treatment promotion activities going on at the event that are absolutely within the parameters of those $1,400 grants. So yes, I'd agree with you that public money went to that event, but it was not to, it was not to put the entire event on. It was for the specific activities that the mission of Wyoming AIDS Assistance and our communicable disease unit share to help folks with HIV, AIDS, and STDs.
And they did heavily promote on their page that rapid HIV testing is available, and did promote prevention efforts. I don't know if you're aware. I'm assuming you've had enough communication about this. You've reviewed and are kind of aware of the situation and will, be more vigilant. You, Representative Trio, you had a question.
Kind of a question and a statement, Mr. Chair. Thank you. We're sitting here and we're discussing alcohol at fundraising events. Wouldn't you say that the difference between a fundraising event for a school or a hospital and having alcohol is different than holding an educational fundraising event to prevent STIs, when the number one leading to STIs is alcohol? So does it make sense to have an educational meeting and notification event with alcohol on the one thing that's causing the problem? That's the difference. Wouldn't you agree?
Mr. Chairman, Representative Trujillo, again, per the previous comments, we'll absolutely review what's appropriate in the future with grants like this. Our funding was not to promote alcohol use at an event, and it was really for the specific activities that the organization and the fundraising that it was for the population living with and dealing with HIV and AIDS. That was where our funding was intended. Should that be cleaned up in the future, we notice if
there's no state taxpayer dollars and the federal government gives us these dollars as a pass-through specifically for these type of events across the board.
Mr. Chairman, these communicable disease unit funds are all federal. Yes, simple answer is yes.
Senator Hutchings, and I'll go back to Rose.
Thank you. This is just a kind of a heap on kind of thing. The question was, there are groups or comments that there are groups that serve alcohol at events, and get us a list of those. I think when you hear complete with salty language, dirty jokes, and booze aplenty, parental discretion is strongly advised is a lot different than maybe providing beer, maybe some mixed drinks. But booze aplenty really sounds like the hell on wheels float at the Cheyenne Frontier Day parade. That's what I envision, instead of a few people sipping wine, drinks, or whatever. I think those are the kind of things that we're concerned about, a list of those, not just who has liquor at an event, if that makes sense to you, sir. Thank you.
Mr. Chairman,
Yep.
Senator Hutchings, just to be clear, I'm not sure for all of our grant recipients, we will know what if alcohol was served or not. This happens to have been widely publicized for a variety of reasons, but we'll provide the information that we have, including the list of grant recipients for these funds.
Representative Ward.
Thank you, Mr. Chairman. Director Johansson, I was wondering, I believe, don't the grant guidelines state that the Department of Health has to approve promotional materials?
If you know.
Mr. Chairman, Representative Ward, yes, I believe so. I'll have to check into whether any promotional materials for this event were reviewed and approved. I know that, again, listing Department of Health on as a sponsor was likely incorrect, but I'll double check that and get back to you.
Representative Penn.
Just for clarity, I'm reading from the grant application. It says all advertisements under this funding must be approved by the CDU Prevention Program Manager prior to publishing. So that's what the application says.
Okay, further on this topic. Any other, we have agency updates tomorrow still as well, correct? But you'll be joining us remotely. I know you'll miss us.
Mr. Chairman, I absolutely will miss you, but I'll be available virtually. I think we're on.
I mean, I guess there's a motion on the table. I don't know if that follows A within our interim topics, and B, I guess I'd like a lot more discussion and information before I have to make that vote on some amorphous words, but discussion on that motion, assuming we can find a way that it's in our interim topics, which it might be. Perhaps just give me a little more information, if you would, Representative Penn, on what you're thinking, what type of fund, maybe some more parameters if a bill does get drafted. Sure, repeat the motion and give us some information.
Certainly, Mr. Chairman. So the motion was to draft a bill to prohibit state funds to be spent on sexually explicit events. And so my thought is, you know, we've said that there are some review things that need to take place there in the applications. It said that the review are happening. So in this situation, maybe there isn't a way to know that something is going to happen until after the fact. And so if something does happen and it comes to our attention after the fact, we need to at least be able to say, we need that money back. And I think that provides some guidelines so that when people are receiving these grants, that they understand that if certain parameters, certain standards are not met, that they may lose their funding. And I think that helps put some sideboards on how the money will be used.
So in this case, it was federal funds. Is it including state, like pass through anything it would be your motion as well?
Yeah, I mean, my point is really tax dollars. And so certainly federal funds, I guess we should amend that to say tax funds, yes.
Discussion, Representative Yoon.
Mr. Chairman, thank you. So maybe my question to the committee is, I mean, I understand that it's trying to target this specific drag show, We have, in Jackson, we have an annual fundraiser for women's healthcare called Bras for a Cause, and it is literally a bra auction. That's a runway down a bra auction with auctioning off these like designed bras by local artists to raise money. I would think that that could be taken as sexually explicit. So I guess where's the line and how sexually explicit are we talking about when we talk about using funds at an event that's supposed to be used for prevention, no matter what the event is, but the funds are supposed to be used for prevention. Where is the line, or is it only LGBTQ?
So these kind of concepts are better addressed in like a rule or reg or a grant application. Because when we do something too broad, it worries me. But anything like that existing that you can off the top of your head?
Mr. Chairman, I'm not aware of anything that would meet that purpose. I could certainly look if I'm mistaken. Typically with grant funds, obviously the allowable costs and the grant parameters, whether it's federal or another granting entity, have to be followed. But we also look to state law and state rule if there's any governing parameters there. This one I'd have to do a deep dive to see if there's anything that would help this effort.
Representative Ward.
Thank you, Mr. Chairman. I think that the motion is about sexually explicit anything, not just LGBTQ. It says in our Constitution that we're to encourage morality and discourage vice. So taxpayer funds going to sexually explicit material of any kind is inappropriate.
Other discussion on the motion. I would imagine you're gonna get the information either way. Senator
Mr.
Doc.
Chairman, the event that was referenced in Jackson, is that a taxpayer event? I'm not clear what.
Do you know?
Mr. Chairman, no, but it is an example of a fundraiser that could make sense to have because it goes to, some of that money goes to St. John's Health Foundation, which is not a taxpayer funded entity, right? It's a nonprofit that helps support services at the hospital. But it could make sense for them to apply for funds to allow testing at that event because it's one where a bunch of adults go to, where you could have those demographics that you want to ensure get tested.
Mr. Chairman, understood. I think, but the motion, I take it back to the motion. It was based on taxpayer, not the type of event the taxpayer dollars used for that.
All right, further discussion. I guess even if we have a bill draft, you're gonna give us a list either way of all of the grantees. And maybe even by the end of the day. All right, seeing no further discussion on the motion, all those in favor of a bill draft to eliminate the what?
Public comment.
Oh, we can take public comment, sure. I guess the motion got moved. Yeah, we'll take public comment. It's kind of we're out of order right now anyway, but go ahead, Mr. Downing.
Well, Mr. Chairman, Jonathan Downing, testifying on behalf of Wyoming Press Association, not to the issue of the bill. This has
Really, is it within our management council topics? And I haven't spent any quality time in the last 5 minutes looking. But hey, we could ask LSO. Anna?
Mr. Chairman, I think the way that we have agency reports written, it would probably fit under there. Because it says that you could use that topic to address any other legislative issues.
Interesting. Mr. Downing,
Thank you, Mr. Chairman, and just noticing it for the record.
thanks.
Question for the witness.
Now that you're here, Senator Downing.
Yeah, as long as you're here, then are you saying you accept that as part of the interim topic list then?
Mr. Chairman, not accepting that particular bill as part of the topic list, but just we've had some concerns over the last few meetings where you have issues come up that aren't noticed. And that's not just at a legislative committee level, that's also at local government level. And so in that respect, this wasn't noticed as far as a potential topic. And so if you're going to have these types of policy issues being discussed, then I would encourage that it be noticed a little bit more thoroughly than coming up during the committee report.
Senator Bouchard?
Thank you, Mr. Chairman. Ever since I've been in the legislature, this has been the process. If we just move to draft a bill, we're not at a vote. We're not at a point where public discussion at that point. So I don't see
Yes.
where there's objection here. I mean, we're just talking about moving a draft forward for draft, not necessarily presenting a draft to the public yet.
Technically, we haven't got to agency reports yet, but go ahead, Senator Doxter.
Mr. Chairman, then if we draft it, then that's when it goes out and notice and publish. And we make sure the public understands that it's under consideration. Okay.
It just seems like it's a little out of order. We weren't truly on the broad topic of the health department. It did come out. I appreciate that. Representative Yin?
Maybe to reframe Mr. Downing's concern, I think the concern is ultimately that we are taking on any business at all that isn't really noticed on the agenda. So if we were in agency reports, I think maybe it would make sense if this was a reply during agency reports, but I think the concern ultimately with the Press Association is how do you cover something that has business taken, like a vote to draft a bill, during a time where there isn't notice that this isn't a topic, that this is a topic that we're even bringing up.
I think your concerns this is a little bit out of protocol. It just never used to happen, right? So now that it does. Appreciate it, Mr. Dunn. All right, further discussion on the motion. Any other public comment? I had a hand raised as a panelist, but apparently I hit decline to come in, making sure to have other public comment. Okay. All those in favor of the motion to have a bill drafted for our next meeting, please say aye. Opposed, say no. No. Okay, LSO, if you would draft and work with the Department of Health on maybe, getting a little more structure on that and see what we can come up with. Back to our previously scheduled topic. Next up is opioids, but I guess. Oh, we're not even to that. We're still in pharmacology. We're just getting warmed up. I thought the hospital was going to get up and join us. First up, let's go with, I guess, the Medical Society. They want to talk about step therapy and also have a role in certainly opioids. Ms. Bush, if now's a good time. I know you brought the concern of step therapy to us at our interim topics meeting. And then also, I guess maybe we'll jump into that and then bring you back another time when it comes to opioids. However you want to proceed, we're very loose this afternoon. Go ahead.
Mr. Chairman, members of the committee, Sheila Bush with the State Medical Society. I'm very conscious of the time, and so I will try and make this pretty brief. We did provide some documents ahead of time that we hope would be helpful or just better inform the topic. I think the easiest way to conceptualize or think about step therapy is to go back and talk about or think about prior authorization. The bulk of the prior authorization conversation really related to procedures. The bill that we ended up with had a sprinkling of some other topics, including one small aspect of step therapy. And so when you think of step therapy, if you think about the same principles that were applied and kind of talked about with regard to prior authorization, it's similar in the sense that it's the relationship between insurance companies and providers and patients, prescribers, and the mechanism by which patients are allowed to seek the medication or obtain the medication that their prescriber thinks is best for them. And so just working through the documents that the Medical Society provided, definition of step therapy is the one that we already put in the prior authorization law. And so there's a model bill that was provided. It came from Minnesota. It, I think, arguably will not be with our insurance partners and everyone across the industry and many of you to get to the right place and strike the right balance. The Medical Society is very cognizant of the fact that we're continually having to walk a pretty fine line between patient access and prescriber autonomy, giving providers the latitude that they need to truly deliver the best care for people when they need it, and balancing that with finite resources. And our insurance companies shoulder the burden of protecting finite resources and trying to mitigate risk and make sure that that dollar goes as far as they can have that dollar go to provide care for everyone within their population. And we appreciate that and respect that tension that's going to exist. And so we look forward to a conversation with them and with all of you on how we get to the best place and what that compromise will look like. Our primary goals, if you'll look through I gave just some quick bullets. A win for us at the end of this would be a very transparent, easy way for patients and providers to seek an override or an exception to a step therapy requirement. And so that would look like if the patient had tried and failed on the required drug, that language is already in the prior authorization bill that we passed. And so I included it again just to make sure that we were all on the same page and that any action, if an action is taken, that we're just cognizant of the fact that that one provision does live in the prior authorization bill that we passed this past session. And that was specific just to that try and fail, that an insurance company would be prohibited from requiring a patient to try again a medication that they had previously tried and already failed. The other things were providing an override to a patient if the medication that the insurance company is requiring as part of the step process is going to delay treatment or will cause irreversible consequences. If the required treatment is contraindicated and will or is likely to cause an adverse reaction. If the required treatment will or is expected to prevent a patient from working or fulfilling activities of daily life, or if the patient is stable on their current medication. And so with all of those, I'm sure that there's a lot of conversation to be had about how all of that gets defined and how we, again,
Questions from Medical Society. Representative Trujillo.
Thank you, Mr. Chair. I'm looking at the exceptions for this. So let's say I have insurance and I do my whole step therapy and I'm in the process. And then I end up with new insurance. And that insurance is saying, well, you need to do these steps. Is there an exception for that piece in here? I might not have read it. That's
Mr. Chairman, Representative Trujillo, I think what you're getting at is if you have previously failed, right? Not being required to fail that medication again, is that right?
No, I did the step therapy, right? And I'm on my third step and I'm doing the process with my current insurance. And then I get a new job and I go into a new insurance and they're requiring me to do that again. Is there an exception? And yeah,
Is that
thank you.
possible?
Yeah.
Do you know, Ms. Bush?
Mr. Chairman, I believe, and I'll defer it back to the committee also, because I think that what you are referring to is a repeat of the process, right? So we did one insurance company through your previous employer require you to participate in the step therapy process, and then you went to a different company, and can they require you to repeat that step therapy process? I think that the language we passed in the prior authorization bill actually prohibits that, and it extends across insurance companies. So I do think that we got there with that component, but I could be wrong, and I'm happy to be corrected.
Thank you. I just wasn't clear on that. Thank you.
Representative Clausen, question?
Thank you, Mr. Chair. No question, just confirming what Ms. Bush just said. That was definitely the intent of the way the bill was written and the law passed.
Okay. Further questions for Medical Society? Seeing none. Thank you. Maybe we'll talk step therapy for a bit and then we'll come back and talk opioids if that works. Feel great. Anyone else want to talk about step therapy in general? And the possibility of spending some time on it this year? Mr. O'Day. And Mr. Spencer, Mr. Hernandez. Welcome. We'll wait for all three of you to come up and Heather, you have the floor first. Go ahead.
Good afternoon, Mr. Chairman. Thank you again. My name is Heather Roday from Blue Cross Blue Shield of Wyoming. Just some quick comments. I think that the big thought that we would have is that we did include a portion of step therapy in the plan with more advances in step therapy. Thank you.
Any immediate questions? Seeing none. Well, Mr. Spencer, your mic's hot, so go ahead.
Mr. Chairman, members of the committee, my apologies, Doctor. Bruce Spencer representing the Mountain Health Co-op. And I would concur with Ms. Roday's comments. We spent a fair amount of time with our partner providers in discussing an appropriate way to resolve some concerns about step therapy. It was not part of the interim committee's discussion of topics, but when we got together to come up with an agreed bill that we could present the legislature, that topic came up. And we spent a fair amount of time working on it, and the result is what you see in House Bill 14. We believe that is a sincere effort on our part to resolve step therapy concerns and would greatly appreciate the opportunity to have it work and to have some discussion with our provider partners if they're having problems before new legislation is again proposed and we have to comply with. We'd like to give the opportunity for House Bill 14 to take effect and some time to see if it works. I also believe the department has some rulemaking responsibilities under House Bill 14. We haven't had a chance to see what those rules might be and how they might impact prior authorization. And again, we would respectfully request the opportunity to allow that to occur before we explore new avenues of statutory regulation. Please give us a chance to see if this one works first. Thank you.
Questions? Dr. Mendez Harper.
Hello, my name is Lugina Mendez Harper. I'm a pharmacist. I work with Prime Therapeutics, which is a pharmacy benefit manager. We're owned by 18 Blue Cross Blue Shield plans across the United States, including Blue Cross Blue Shield of Wyoming. I want to echo Bruce's sentiment. Certainly, within the construct of the prior authorization bill that was passed earlier this year, when we were having stakeholder meetings, the medical society and others expressed some concern about step therapy, which is, again, outside of the scope of prior auth. But there's similar programs, and so we do have a provision in there. And to answer your question, Representative Trujillo, I wrote it down actually because I had the same question that you've done that, then you won't have to redo that whole process. So again, I think the intent is there to try and address, and that was identified by the stakeholders as kind of the most important concern regarding step therapy was this continuation of care and not having to re-go through the same steps you've already gone through before. So again, it is there, and we did incorporate that because it was expressed as the highest priority related to STEP. And we would just like to request time to let us have this bill go into effect, have the Department of Insurance have rulemaking, and then have the opportunity for us to continue to discuss what are the issues that are specific to STEP. Let us validate it and then determine, do we need a legislative solution, or is this something that we can get together, have a meeting and resolve it amongst the stakeholders that are in the state here in Wyoming. So thank you.
Questions for Dr. Mendez Harper? Seeing none. Thank you all for being here. Mr. Bowley.
Good afternoon, Mr. Chairman, committee members, Eric Boley with Wyoming Hospital Association, and we're with the Medical Society on this one. We did some good work with the prior authorization bill, and we did get some provisions in there when it came to step therapy. We don't think that the bill went far enough, and we actually let our partners know that we'd be discussing this again this year. I think that even though we're waiting for rules to be promulgated and we're waiting for House Bill 14 to take effect, this process takes a while. And I think it makes sense for us to continue to look at ways to improve access to care for our patients. Step therapy is another great example of how insurance companies oftentimes delay care, how it makes it more and more difficult for patients to receive care in a timely manner and in the right fashion. And so I think that spending the interim working on something that's stronger, that protects our patients, that helps our providers, that guarantees surety for the patients that are receiving that care makes sense. We would ask that we work on this through the interim. And I think we could start with what the draft bill that the Medical Society presented, and then we could work on it just like we did this whole last year on prior authorization. And I'd answer any questions. Thank you.
You want a whole nother year on?
I'm just curious your perspective, and maybe you can elucidate a little bit more why you think the previous legislation doesn't go far enough. Thanks.
Mr. Bowley.
Mr. Chairman and Representative Ward, I just think we spent some time on step therapy in House Bill 14. And I think Ms. Bush could probably help with some of this, but I don't think we addressed all of the concerns. And I think Representative Treehill brought up an important point that was covered in House Bill 14, but there are situations where I think we could just improve how quickly and how easily our patients could receive that care. And a lot of it has to do with pricing of drugs. It has to do with manufacturers of drugs, generics versus name brand. Starting and stopping, trying, and I think both of our healthcare providers are aware of that as well as they work with their patients. I just think that we can make it stronger and better for the patients.
Other questions? Seeing none. Thank you, Mr. Bowley.
Thank you.
Other public comment. Let me check online as well here. Not seeing online, not seeing any here on step therapy. Okay, maybe we can talk about opioids next, and then at the end, we'll just kind of discuss as a committee next steps you want to take. So when it comes to the opioid epidemic that we're facing with, actually, Director Johansson, I know you're doing agency updates tomorrow, but we didn't quite cover. I know. I understand why you sit in the back row. But certainly there was a really big article last week in one of our statewide online newspapers about the opioid settlement. And I've been to a couple of conferences on I mean, every state is saying there's a lot of money, but somehow it's not getting out the door quick enough. And so maybe you could just kind of kick us off on where we are in Wyoming when it comes to kind of opioid use and the money we've been given to get out the door, and then where you think as a department we should continue with our efforts.
Happy to provide that update, Mr. Chairman. So and signal at me if I'm going into too much detail, can move faster. About a year ago, a little more than a year ago, many states were engaged in a settlement agreement with some site that can shoot the link to the committee. That settlement allocated, a settlement amount that comes in over many years. I believe it's about 15 years that the funding will come in. And 65% of that settlement goes directly to counties and municipalities. Municipalities of certain size. I think we might have one that met that threshold in Wyoming. The rest of that 65% gets distributed on a county basis. The 35% share, a 35% share comes to the state of Wyoming, and that's what I'll address briefly here. So it's a smaller percentage of the overall settlement, but still not an insignificant amount of funding. So we have received 2 allotments out of the settlement that again comes in over many years. The first was $829,000. The most recent in January of 2023 was $3.5 million. And I believe there's an impending 2024 settlement allotment to the state of an additional $3.5 million. So that I'm not sure if we've received that yet, but I know it's likely in process if it's not already in the Attorney General's office now. So like I mentioned, it's allocated in installments over approximately 15 years. Because of that amount and because of the timing that it works on, we were kind of challenged with balancing, creating new programming with supplementing existing programming, and have mostly elected to allocate along the latter, supplement existing programming, but there's some exceptions there, which I can talk about. And those 2 areas for us in terms of existing programming are in treatment. So opioid treatment, typically flowing through our behavioral health division, through our community mental health and substance use center funding. And then on the prevention side. So community prevention, mitigation efforts, things of that nature that typically flow through our public health division. And we've kind of split the money equally across different program areas. On the treatment side, we have planned about 1.1 million, little more than 1.1 million of the settlement funding to go to treatment. So medication assisted treatment for opioid use disorder, telehealth expansion, and priority population outreach. Again, largely flowing through our current behavioral health division programming. Of that 1.2 million, approximately 600,000 has been encumbered. And to date in that bucket, about 22,000 has been expended. I'm not recalling the article specifically, but I know some of the concern was the challenge in spending these funds quickly. You'll see that on the state side too, getting access to various recovery services for folks who have had opioid use disorder and are in recovery. We also have some training and workforce development programs for people who work in that field, again, supplementing existing programming we have in our behavioral health division. And on the public health side, so in the prevention category, we have opioid prevention testing capacity, of which we've planned about $300,000 to ensure or coordinate state level opioid testing. We have a qualitative opioid use project that's about $24,000. So qualitative data from people with lived experience, really trying to get survey the folks who have used opioids or struggle with opioid use disorder. We have some workforce assistance toolkits that are in process for best practices and development of a toolkit for workplace opioid abuse and misuse prevention. We have some media allocated in this effort, around $100,000. Alternatives for opioids in pain management practices on the prevention side, approximately $625,000 for various preventions and health systems, again, looking at alternatives in opioid use for pain management in the healthcare system. Public education campaign where we've planned but have not expended around $500,000 for that. And then importantly, this committee and the legislature a couple of years ago legislated or passed a bill legislating plans of safe care between hospitals, Department of Family Services, Department of Health, Child Development Centers, et cetera. And we thought this was a good opportunity with settlement funds to supplement that effort since it is somewhat new. to be able to provide some funding, really supporting service providers involved in plans of safe care. Again, children and recovering mothers model is something that's being implemented per that legislation, looking at education and preventive services for postpartum mothers where there might be opioid use involved, and really, again, supplementing those plans of safe care efforts. And last but certainly not least, the Department of Health for the past several years has been distributing and supplying various community entities with opioid antagonist agents, so things like naloxone. And so we're using some of this funding right now, planned about $300,000 of what we have for additional provision of naloxone free of charge to agencies, businesses, organizations. I've had several sheriffs reach out to me on the problem of opioids entering our correction system, entering our jails and detention centers. There's technology that's available, body scanners, et cetera. So we're investigating if this would be an appropriate use with the Department of Health statewide funds and potentially with some of the funds available to the counties to support our law enforcement agencies. So a little bit early in the process, Mr. Chairman, but certainly like our tobacco settlement funds that we're also familiar with over the last couple of decades, trying to put these to best use, not overspend early, but really have a strategic approach. And that's challenging, given that there's quite a bit of pressure and demand to get the money out the door quickly.
As far as you know, they're not going anywhere immoral yet?
Sorry, repeat the question, Mr. Chairman.
Any of the funding being spent in anything we would consider immoral?
Mr. Chairman, no comment there.
Okay. Representative O'Hearn.
Thank you, Mr. Chairman. You just mentioned it again, getting the money out the door quickly. Was there a backlog of where this money should be going?
Mr. Chairman, Representative O'Hearn, it's a good question. And no, I wouldn't say there's a backlog. To be clear and really not trying to antagonize the committee here, we've been working on the opioid use issue for a number of years, not saying perfectly, and there's certainly more that can be done. Opioid use in terms of our greater public health substance abuse issues, it's not always number one. It does generate a lot of energy, and with a big nationwide settlement like this, there's quite a bit of pressure to spend, which is why I mentioned a little bit of a more conservative approach of looking at where we can supplement the existing infrastructure that's in place. Our existing providers are what I think is successful in Wyoming, that prevention dollars really are decentralized, where communities decide what's the best way to spend them. And I think that's applicable here, where we really want to use these funds on the prevention side to support what our local coalitions, our local providers think is best versus a top-down state solution. Now, having said that, I'll contradict myself, because some of those areas around corrections, judiciary, where there might very well be a need to support those law enforcement agencies with something more comprehensive. That's what we're looking into now.
Yeah, Reverend Clouston.
Thank you, Mr. Chairman. Thank you. As far as you kind of mentioned on it, other alternatives to opioids. I mean, one way to prevent the problem is just not to put people on them, and they have their place. We all know that. But what are some of the alternatives that you came up with?
That health systems have started implementing or are exploring, whether it's in a hospital setting or another direct care setting, using non-opioid agents. But that's about the extent of my knowledge of what's appropriate there, other than what you said, just not using them.
Representative Hornock.
Thank you, Mr. Chairman. Maybe I missed it, but are any of these dollars potentially going to our drug treatment court system that's in place?
Director?
Mr. Chairman, Representative Hornock, again, sorry for the lack of preparation here. It was not on the agenda, so I could easily get more information. Let me double check on that. Again, that would be one of our existing programs that doesn't have to be created new, but certainly has clients involved in it where, opioids or opioid related substance use might be part of the judicial issue. I'm not seeing it in our top level data here that was prepared quickly, but I'll get back to you on that. Certainly could be an avenue.
Representative Trujillo.
Thank you, Mr. Chair. You mentioned working with the judicials and our sheriff's departments, and we recently in Laramie County had our sheriff, talk about treatment in the facilities, and you mentioned prevention and getting the opioids into the jail, but are you working with them to maybe put the programs inside as well to treat the offender before they come back out?
Mr. Chairman, Representative Trujillo, to be clear, I have not had direct conversations with the Laramie County Sheriff on this issue, but certainly can. So I'm not aware of treatment programming that these funds are supporting within the walls of a detention center. Not to say the uses of these funds couldn't be expanded in that direction, but those discussions have not happened yet.
Senator Bouchard.
Yeah, Mr. Chairman, thanks. I want to chime in on Laramie County. The sheriff there is actually standing up a program inside the jail. So, I mean, I think it would be worth it for the health department to go down there and look at that, because it's probably going to be the first one of its kind in the whole state. And we've kept hearing all the roadblocks to why we can't do something at the county level. They look like they're doing it. It's in their budget. They have a director to keep quality assurance in that program. So it certainly is worth looking at to see if we can put some of those funds there. And they're
the state, but more than happy to reach out. It's in my neck of the woods, so don't have to drive to Afton for those conversations, but happy to do that.
And if there is something formal, maybe send the 4 or 5 of us from Laramie County on the committee, we can all go meet together or something and get a better overview. Senator Bouchard, follow up.
Mr. Chairman, I actually invited them to our committee. I didn't tell you yet, but I would like to reach out to them at a specific time whenever is available, where they could come and present what they're doing down there.
I think our 3rd meeting's in Cheyenne, and assuming we don't get any more interesting topics, we'll put them on the agenda in August. Letting Director Johansson off the hot seat. Anything else on opioids or Good Samaritan law while I have you up here?
No, Mr. Chairman, I might just mention, again, want to be an open book here. Should members on this committee or your constituents have suggestions, ideas for the health department, we welcome that. Not trying to be closed door about how these funds are going to be spent over the next 15 years. The strategy's hard on that timeline. Again, that balance between new things, which you see a lot of states aggressively spending money on, versus supporting existing programs and infrastructure. I'm not saying we have the balance perfectly. It's perfect, but should you or your constituents have suggestions, please send them my way.
All right, thank you very much. Let's talk about the Good Samaritan law. We heard about this some in the interim. Miss Somerville, I know you're coming up. Miss Cartwright as well is online. Andy, do you want the floor, or do you want me to turn it over to Jan? Go ahead, Miss Somerville.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for WAMSAC, and I'm here to talk a little bit about Good Samaritan law. This is a topic that was considered by the legislature back in 2017. There's a bill draft. It was House Bill 62 that I believe was included in your packet. It made it through the House, I believe, and then did not make it through the Senate side. And I believe that was the last time that this topic was discussed. And just generally speaking, this is really about granting very limited immunity for criminal prosecution for people that call in and basically they call 911 when there's an overdose. When somebody has, for example, overdosed on opioids, that they will not be charged with. I believe in this bill, in House Bill 62, it was criminal possession or use of an illegal substance. So as you can see through the bill, just walking through page 1 of the old bill is title page. Page 2 lays out I believe it's 4 or 5, what specific criminal offenses, is possession of controlled substance and use of a controlled substance that somebody would be immune for if they did all of the above. So Mr. Chairman, we've got a group together that includes law enforcement from a couple of different levels, health providers, several health organizations, recovery organizations. It's a pretty big group this time that has come together and discussed this at length. And I think the hope is that this committee will move forward with a bill draft that we can look at the next meeting. Mr. Chairman, with that, I'd be happy to take any questions, but I'd also like to turn it over to Ms. Cartwright online.
Hey, Jan, if you can hear us, floor is yours.
Thank you, Mr.
I know
Chairman.
there's a time delay.
Yeah, sorry. Just 1 second here. Mr. Chairman, I'm Jan Cartwright, representing the Wyoming Public Health Association. Last week, I shared a 50-state comparison report with all of the committee members and would like to quickly reference that here. Our state is one of only 2 without any law that addresses overdose tragedies. The state reports that Wyoming saw 124 overdose deaths in 2022, with most of them being unintentional. And as you stated, with only a small portion of the opioid settlement money being spent by the counties and communities, there are many negative outcomes waiting to happen. Now, I wasn't involved in the previous debate, so I'm not as knowledgeable as I'd like to be. And I acknowledge that this is a complex issue. However, as described by Ms. Somerville, hopefully the committee will continue this effort to include the previous bill language and further conversations with both the mental health, public health, and law enforcement communities. Thank you.
Thank you. Any questions from Ms. Somerville or Ms. Cartwright? Go ahead, Senator Hutchings.
Thank you, Mr. Chair. The question is, why are we calling this a Good Samaritan law? Normally, when I look up the Good Samaritan law, it's someone who offers legal protection to people who give reasonable assistance to those who are or whom they believe to be injured, ill, in peril, or otherwise incapacitated. What I see in this bill is someone is participating in a crime. Me with that. It just kind of bothers me seeing this as a Good Samaritan law when I'm actually not a good person at that time. Thank you, ma'am.
Ms. Somerville.
Thank you, Mr. Chairman. Senator Hutchings. So I don't know that I'll be able to completely answer your question, because I think part of your question in terms of intent or the situation you described, if you were to inject somebody else with drugs, I think that would be a question for law enforcement to determine if it was actually one of these 2 specific crimes that are listed here, if that was use or possession, or if it was something else. So I couldn't speak to a situation like that. I think in terms of why we call it a Good Samaritan law, the idea is people don't intentionally try to overdose without other potential considerations, such as suicidality. And if somebody is overdosing, we want the person standing next to them or the person that finds them to call 911. We know that getting Narcan and responding to them as quickly as possible is the best chance that we have at saving their lives. And I think the concern, and certainly the conversation nationwide, has been if somebody is standing there and they've been smoking pot, we don't want them to be afraid to call 911 for their friend that's dying or the person next to them that's dying. And so I think that's the intent behind the Good Samaritan law. I think that it would be a very ripe discussion, and we can bring some of our law enforcement partners to the next meeting if the committee decides to move a draft of this bill forward, to ask some more of those specific questions about when somebody when would be appropriate for the immunity, when would it apply, and in what other circumstances it wouldn't be.
Other questions? See,
Mr. Chairman.
oh, do you want Ms. Cartwright? Additional thoughts, Jan?
Thank you, Mr. Chairman. I worked on a Good Samaritan law when I worked for the American Heart Association. And that was if somebody's having a heart attack and a bystander tries to help them, then the person who survives doesn't turn around and sue the bystander because they had a certain level of brain damage or something like that. We want people to act on behalf of other people. This is what we're in this world for. We're here together to help one another. And it doesn't matter. I mean, are we going to let somebody who was shot illegally with a gun bleed out because they were in the vicinity of bad acts? I just really disagree with this premise that somehow if somebody has caused their possible death by using drugs, that they should just be let to die. Thank you, Mr. Chairman.
I intended that kind of response at all. I was asking why you're calling it Good Samaritan when in this case it appears that someone is participating in an illegal activity. They want immunity. I'm just saying is that it is a Good Samaritan in essence, but I was just wondering why you were calling it that. I'm not saying let her die because I injected her. I'm not saying that. I just wanted to understand the nomenclature, if that makes sense to you.
Yeah.
Thank you.
And I do, and we just have colloquially called it the Good Samaritan law, even though the actual bill is immunity for drug overdose reporting, because it does fall in line with similar provisions we've had. Like if you take your friend drinking at the bar all night and you're the one who has the bar tab, but they get alcohol poisoning, you should still be calling 911. And so, yeah, perhaps we have been a little flippant in just calling it the Good Samaritan law when these are not people at their highest and best facilities. Would that be correct, Ms. Somerville?
Mr. Chairman, and to Senator Hutchins' original question, I would agree.
Representative Hornock.
Thank you, Mr. Chairman. Just generally, as we work through this, it would be nice to know what other instances in Wyoming statute that we have this kind of Good Samaritan idea, so that we can compare it to other instances. If it is in Wyoming law, I would like to know, I don't know how else you get Jerry and George and Elaine and Kramer off the street. So just throwing that out.
And if we move this forward, I would imagine we would do a thorough review of how this works and where other places in our laws this would come into play. All right, off the hot seat. Thank you both for being here. Anything else in pharmacology? Any public comment that we didn't discuss in the world of drugs that anyone in the audience feels overwhelmed to talk about? Seeing none. So committee, a couple of things came up there. I don't know if you want to pursue any of them in this interim. Obviously my name is on the immunity for drug overdose reporting bill from 6 years ago at the start of when the opioid epidemic hit Wyoming, and it is not mitigated that much. I've lost a couple people in our city in the last 2 years. So if anybody has a motion or thoughts on any of the ideas last hour they want to move, now would be the right time. I know. That passes. Yes. Okay. Anything else the committee wishes to pursue? Seeing none. Let's jump into maternity deserts, as they're also being colloquially called, which may not be the best terminology. And anybody need a break? It's 3:20. You want to take a 10-minute? We didn't take a morning break, so let's take a 10-minute break. We'll come back at 3:30. We'll see if we can catch the YouTube up. There's about a 22-second lag from every All right, as we are slowly coming back together here. I did say 3:30, so I'm diligently trying. As people are taking their seats. I have more people in the audience leaving their seats than currently sitting. So committee, our number one topic from Management Council, and that almost all of you in some way, shape, or form selected for the interim, was on maternity care and child care. As we all know, Wyoming, being the least populated state, has serious issues across the board, from providers to facilities to adequate facilities for daycares, some labor shortages. And so we're somehow, as a committee, going to address all that and solve it this interim. Hopefully, we're at least going to make a dent in it. So with that, let's start with Jen Davis from the governor's office to kick us off.
Good afternoon, everyone. Jen Davis from the Governor's Office, Health and Human Service Policy Advisor. Thank you for letting me talk with you all this afternoon about maternity issues. I know we have lots of people that are here today to speak about this, so I'll try to keep it as brief as possible. But I really want to be able to set the stage for you all to really understand the issue that we have been hearing. We have had a subcommittee of the Governor's Health Task Force for OB for probably about the last 9 months that's been actively working on OB issues very closely with the Department of Health, Maternal Child Health Unit. So just want to share a little bit of information with you today on what it is information that I thought would be helpful to set the stage for you all. Katie, you can go to the next one. So this is the webinar. I put the link there in your notes if you all would like to go on and get all of the information from that. I'll touch on just the high points today from that, but that is the actual link where you can get the full slide deck and watch the information if you'd like. So at the national level, they have two different systems that they look at. They have the pregnancy mortality surveillance system, and then a state and local maternal mortality review committees. And from that data, they look at death certificates to really see what some of the issues are related to maternity care. So in the next slide here, the pregnancy mortality surveillance system, this just gives you some information that each year the CDC requests the 52 reporting areas, which is all of our states, including Wyoming. And they voluntarily send copies of death reports for women who died during pregnancy or within the first year after delivery. This then is linked to live and fetal death records, if those are applicable. And that information then is summarized in some of this data that I'll be reporting to you. The link also is at the bottom for the larger report if you want to go in and look at some more detailed information from each of the states that participate. And all of them participate in the PMSS, and then 36 states participate in the MMRC. So this here just gives you an idea of the pregnancy-related mortality by year. And what I just wanted to point out for all of you to see is this is a growing problem. You can see from 2000 to 2019 that we have had a pretty steady increase of maternal mortality across the nation. You can go to the next one, Katie. This one here breaks it down by race and ethnicity. So you can see from this chart that the Native Hawaiian and Pacific Islanders are the highest, followed by Black, American Indian, and then white, followed by Asian and Hispanic. So just gives you an idea that this bars are what they consider rural in this data. So you can see that being in a rural area also has higher rates of maternal mortality. And we'll talk about some of those issues today as we get into all of this. So this is the MMRC, which I mentioned is the local reviews, and Wyoming participates in that. And the data that you see next includes the 36 states that are participating in that. And what we see here is they really looked at timing of deaths related to pregnancy. So 22% of those were during pregnancy, 13 day of delivery, 12 the first 6 days, 23% in the 7 to 42 days, and then 30% in 43 days to 1 year after the delivery.
So do you know if we go back, it says it's pregnancy related death after 43 days after the fact. They tie that back into it being pregnancy related. How, if you know?
So the next slide here will give you some examples of the things that they look at. Like if there was, Katie, you can go to the next one here. So they look at these different markers here. Was there a cardiovascular incident related to that? Was there, later hemorrhaging related to that? And then you can see at the bottom, mental health conditions. So suicide, other mental health issues. We know that maternal depression is typically diagnosed around 6 weeks postpartum. And so those are some of the issues that they're seeing. And you can see significantly that later pregnancy-related issues were highly related to some mental health issues.
Thank you, Mr. Chairman. Did you want us to wait till the end to ask questions, or can we ask questions now?
Is it okay if we ask questions as you go, Jen?
Yeah.
Okay, jump on in.
Thank you, Mr. Chairman. So a question about the cardiovascular activities. So the data on the preceding slide with the 22, 13, 12, 23, and 30%, what years or year is that from?
That is from the, 2017 through 2019.
Okay. So the type of cardiovascular accidents or incidents that we're talking about, stroke embolism due to
On that, what they determined from this research that they've been doing is looking at those local data points that we just saw, was that about 84% of the pregnancy-related deaths can be determined to be preventable with adequate care or different care mechanisms within that continuum of what we saw on the previous slide. You can go to the next one.
Representative Hornock.
Thank you, Mr. Chairman. Just curious about that slide, 84%. How do we really know? I mean, this is very subjective or relative kind of information. Do you have any further information about that particular slide? How could we prevent these deaths, and is there any more information on that one?
Chairman Zwanitzer and Representative Hornock, when you look at the most frequent underlying causes of pregnancy-related deaths, that slide there that has the cardiovascular injury, amniotic fluid embolism. So what they're saying is from all of these different deaths that they saw, that many of these can be prevented based on adequate care. So for instance, making sure that you're screening for maternal depression and monitoring that so that individuals hopefully do not have suicidal tendencies and die by suicide. Also, in part of that, there were deaths by overdose, making sure that that person is being monitored and preventing that. The point to this data that they're pulling is really looking at what we're going to be talking about in the maternity deserts across the nation is when these care are not available, these are some of the things that we're seeing. And by having adequate care for maternity all the way from prenatal through postnatal, that some of these are preventable based on those issues, making sure that somebody is following them. So for instance, you all passed the 12-month postpartum coverage. So that guarantees that women are followed for that year with care. Prior to that, it was only six weeks of care. So some of those things might have been missed. So that is where that data comes from.
Follow up.
Thank you, Mr. Chairman. Just to make sure I'm following this and the rest of us are as well. All of these statistics that you're showing us are based on those 30.
Will be much better at speaking at than I am, but we track a lot of this information. We do PRAMS data where we survey women after pregnancy. So there is a lot of this data that we do have based in Wyoming, and they can share with you what those actual data marks are. Okay, so the next one here is just an article that I wanted to point out for you all. It was in the Journal of Medicine, really looking at the volume of care and severe maternal morbidity among low and high risk individuals giving birth. So you can go to the next slide, Katie. So basically what this slide here shows is it's showing the number of actual birth volume. So you can see on the annual birth volume, 10 to 110 births per year at a facility compared then to what they consider medium level, medium high, and high level number of births. And what we see is we see a higher mortality and morbidity rate in those that are even low risk patients in facilities that have low volume. And that is because you just don't have necessarily always that highly skilled staff to be able to do that maternity care, which is one of the things that we're seeing in Wyoming. So just wanted to share this slide with you so you can kind of have an idea of what the data is showing us for high risk and low risk patients. We don't have very many hospitals in Wyoming that do high risk deliveries just because we're not equipped to do that. So many of those go to a hospital for delivery if they catch it prior. And so those would be your high risk patients. And you see that those volumes, the numbers are even high there, but nothing like what you're seeing in the low risk populations because your high risk typically are sent out ahead of time anyway. So what I wanted to just share with you all now, as I mentioned, we've had an OB subcommittee of the Health Task Force. And just so you can see kind of who's been participating on that for the last, like I said, about 9 months. We have a variety of physicians on it. We have some family nurse practitioners. We have midwives. We have doulas. The University of Wyoming is on there, Department of Health, the Hospital Association, Medical Society, the Birth and Wellness Center, which is a birthing center in Laramie County. It's the only one we have in the state. We have consumers on there, EMS representatives, the Wyoming Wall of the Information that we needed to be able to move forward. So one of the first things that this group decided to do was a survey of our hospitals to really better understand what was happening in Wyoming with maternity care. We heard a lot of things anecdotally, but we wanted to really make sure that we really knew what hospitals were actually doing deliveries. How many are they doing each year? Are they employing OBs? Are they done by family practitioners? So we just really wanted to get some more information to really understand the landscape better. So I'm going to share with you all the results of that survey here in the next few slides. So Katie, you can go to the next one. So here we had 15 of our hospitals responded to this. I should say 14 hospitals and the one birthing center replied to the survey. And of those, we had 66% of them that say that they are doing labor and delivery services. You can go to the next one, Katie. We also asked of those facilities, how many of you do high-risk deliveries? And as you can see, a large majority do not. Those are sent out of state typically, or if it's one of our smaller hospitals, they may send them to Casper, Cheyenne, or Gillette, one of our bigger hospitals that can take on something a little bit more high risk. But if it's significant, they're usually sent out to our neighboring states that have a high level NICU attached to them. Okay. We also wanted to know who was actually doing deliveries in the hospitals. And what we saw here is that largely it is OBGYN physicians, followed next very closely by family medicine, followed then by midwives, and then so on and so forth. Basically, large majority.
Representative Ward, thoughts?
Thank you, Mr. Chairman. Ms. Davis, you know this is a topic I'm particularly passionate about because I'm a doula, former doula, current sort of practicing doula. Anyway, just want to point out that doulas, it is not under the scope of practice for a doula to deliver babies. Just want that to be clear. But secondly, I wanted to make sure that CPMs were included under the midwife category. Were they? CPMs meaning certified professional midwives. And so those are legal in Wyoming. There's a board that certifies them, but there's also nurse midwives. So when we say midwife in this category, does that include the certified professional midwives?
Chairman Zawanitzer, Representative Ward.
Thank you, Mr. Chairman. That would be great because several of the stories I have heard are that OBs are refusing to work with CPM. So a mom wants to deliver at home, and for low-risk pregnancies, you know, that's a safe and effective way to give birth with a CPM at home. But she needs to work with an OB, obstetrician, in case something goes wrong. And almost all the OBs refuse to work with a CPM, which is causing some moms to go without care. And by without care, I mean they give birth at home with her husband with no medical staff present. Now, given that we don't want that to be happening, how can we improve the partnership between CPMs and OBs?
Chairman Zawanitzer and Representative Ward, very great question. And that has been a topic in some of the discussion there is how do we use our other professionals within the state who have the ability to deliver? What does that look like? The birthing center in Laramie County, like I said, that's new. They use all midwives in their facility. So again, I think it's one of these super complicated healthcare issues of where there is differing opinions, I think, by physicians on each side. And Sheila, I'm sure, will be talking to that some, but that definitely has been part of the conversation of how do we get there if we don't have OBs in the state? We have a hard time recruiting them in the state. How do we use the other skilled staff and what does that look like? And that you'll see in some of the comments here, those are some of the comments that they have. Some are wanting more midwives. Some were saying that in their hospital, midwives aren't allowed to have practice. So that is definitely a huge topic of discussion.
And could be for healthcare authority. Go ahead.
Could be for healthcare authority, yes. Okay, go to the next slide, Katie. So this one here, we had how many providers do you employ that perform labor and delivery? So we really wanted to get a sense, is this being done by people who are employees of the hospital, or are they contracting out these services? So what we saw with the facilities here is that we do have a large amount that are actually direct employees of the hospital. You can go to the next one, Katie. Then what we see is we ask then, how many of you contract? And so like we saw on the previous slide, it appears that we have more that are actually employed an employee of the hospital, but they have the ability to go into their local hospital and deliver. You can go to the next one, Katie. So this one here, we offered just some choices of what they saw, some obstacles to delivering labor and delivery services. Can see the number one issue is this was the inability to employ trained skilled nurses, is what that words are that you're missing there. The second was unable to hire OBGYN physicians. Followed by affordability of the service within the facility, as you'll see in some of the comments later, that this is an expensive line item. And so many of them can't afford to keep doing it with low volumes that they're delivering. And then you can see here insurance and liability for service. It's expensive for OBGYN liability, as well as any family practitioner who's doing deliveries. The cost of insurance is higher than some of the other medical professionals that we see. So that just gives you an idea of some of the top things that we're seeing. You can go to the next one, Katie. So what we did then is they could check those, and then we had them really relate some of the other obstacles they had for offering OB services. And again, I'm just going to highlight a few of these. You guys can read all of these. Many of them were low volume, but they just don't have enough to justify the service line within their budget. And also don't have enough volume to keep current in their skill and make sure that they're competent in doing those deliveries. Delivery is very high risk. We don't always think about it that way because it's just something we think about all the time, people having babies, but it is a very dangerous procedure per se. And so many of them, if they don't have skilled nursing staff available who is competent in that because they don't do enough deliveries, that can be a higher risk, which is some of the things we saw in that national data before that we participate in. Also, what we saw in this is just the ability to hire people to be on call 24/7. You can't just have one OB because babies just come when babies are ready. So you need to have people who are really available at any time, day or night. And that's really difficult if you only have one provider for them to be doing their daily practice and then also on call 24/7. So that was part of the issue as well. And again, we talked about the cost. So you can go to the next one. One other thing that he's in fighting pediatric call in pediatricians. So once the baby is here, then that care usually, if it's not done by a family practitioner, then the care for the infant typically would go to a pediatrician. And they're seeing an increased difficulty on getting pediatricians to do call-in service. So that was something surprising that we saw in the data that we didn't anticipate. And then also cost of living, also some of the call frequency that we talked about, and then also some of the recent legislation of fear of delivery, which you all have heard about throughout the couple of years. So you can go to the next one now, Katie. And then we had here, do you have adequately trained OB nurses? We had about a 50-50 that they did or didn't. And go to the next one. And then we said, do you utilize staff OBs or contract OB nurses? And you can see here, many facilities are doing both. We still have a general shortage of nursing, so we still see a lot of traveling nurses in our facilities that are probably being utilized in this way too. And then also have staff nurses as well. So some of the barriers to allowing other practitioners for delivery and Representative Ward, this goes to the question that you had earlier, is that we need trained OB RNs to be able to do on-call for C-section. You also need either a general surgeon or an OB to be able to do that in case there is a complication and a C-section is necessary. Some of the regulations for labor and delivery, some thought were burdensome and made it cost prohibitive. Lack of staff, equipment, and finances, need to recruit providers. So again, the list goes on. These are mostly things that we've all been hearing about over the past few years. So we had you offer prenatal and postnatal care at your facility. So we also wanted to know if you're delivering, are you also offering the care before and after the delivery? And you can see here the majority of them are. And then if you answered no, are there other providers in your area who are doing that? This is a concerning slide that we see the majority of them say no. So they're not offering it, and then there isn't somebody in the area offering it either. That's where that can be alarming, meaning that people are having to go out of area to receive those services. What we saw here is that there are fewer family practice providers to cover the demands of on-call. Most providers are being trained in OB, or they're going on and doing an OB fellowship. So really trying to get just more people in the work field doing that, also needing more med surg and other people to take on that responsibility so that we can utilize other staffing models like midwives. But we need to have those people available in case something happens. Without a change in regulatory burden, small hospitals just cannot break even in this space if they have low numbers of deliveries. And then another one here is the birth rate in the US has been falling. Even lower birth rates combined with growing Medicare, it'll make it difficult to provide this care for the population in low volume. So, and we're seeing that in Wyoming, that we are getting more of an aging population, meaning that less people in the childbearing ages, and so then decreasing the volumes further, making it cost prohibitive. You can go to the next one, Katie. Then we also asked, is there an interest in regionalizing labor and delivery services? The reason we asked this is we've been talking to Alaska is one of the states who has done this, that we're often compared to for rural healthcare. And they have done a model around regionalization and having different birthing centers. So we were just curious what the appetite would be for that, because then could you increase your volumes within the region to have that competency? And it, as we see there, we've got a mix of, you know, some maybe, some no, and then some yes. Go to the next one. Interest in regionalizing services. One of the things that we wanted to know is, what does that mean for you? Patients have already been traveling, and so it'd be nice to regionalize that. Partnering with other facilities could spread the burden. Some are already working closely together in these areas. We have a large amount of young mothers traveling outside the area. Be interested in regionalizing if we could partner with prenatal and postnatal care at one facility and then ship to neighboring facilities for delivery. So as you can see here, just some different ideas. And again, I won't read all of this stuff to you. You guys have it in front of you. Katie, you can go to the next one. Some of the other things, this is just a continuation. Would you be interested in learning more about engaging collaboration between public-private to address OB deserts in Wyoming, of looking at what does that look like for some of our county-based hospitals, some of our private-based hospitals, since we have a combination of different mechanisms of how our hospitals operate. What can that look like in the public-private sector? Philanthropy has been interested in helping in this space of maternal care too. And, you know, what does that look like? So there was a good response there about looking at options. And then just other comments, as you can see here, one of the things that really kept coming up over and over again in the comments, if you go through and read all of them, is that low volume. We don't have, based on the low volume, people can't keep their skills up to be competent in doing deliveries. We don't have a high level NICU here, so high risk already goes out of state. So this is really just looking at how can we do better for our low risk deliveries in Wyoming. Katie, you can go to the next one. And again, just some further things related to that. And I think that's the last slide there, Katie. Yes. So just wanted to share with you all that survey that we did to give you an idea. We may not have asked all the right questions. There's probably still questions we want to ask. After we did the survey, I think we had a couple more questions of maybe we should have asked this. Representative Ward, your comment. So I think this is just the beginning of things we want to know. Department of Health is going to present to you a lot more detailed information about what things look like in our hospitals and what that trend has been looking like. So again, just really trying to figure out what is it that we really have in Wyoming? What are the specific problems? And then where do we collectively begin to try to solve it? Because it is super complicated and lots of arms around this care. And we just want to start figuring out where's the best place to start.
Best place to start is Senator Bouchard has a question.
Okay.
Thank you, Mr. Chairman. I'm looking at the map that you provided that shows Wyoming. And then when I find that map online, I look at it and Wyoming looks pretty good compared to the other states. And then I see you took in 15 responses, but some of the people that responded, I looked at their counties and they're not represented. 7 counties in the orange, meaning it's a little bit substandard. But when you look at everyone else around us, look at Montana, look at Utah, and then you look at all the Midwestern states, we look like we're doing pretty good compared to them.
Chairman, is there a question?
Would you agree we're okay? Or, I mean, go ahead.
I would like to know what your thoughts about what I just said there. I mean, how could we look like we're not so much the desert when I look at the 30,000 foot view?
Chairman Zawan, or Senator Bouchard. When we look at the data on those sheets, there are places where it doesn't look like it's bad. Cheyenne does probably great. They have lots of physicians. It's easy to recruit there. Casper, same way. When you look at some of our smaller areas, they may be doing deliveries and getting good outcomes, which is great, but they also aren't able to hire the staff and do the volumes that would be necessary to continue that. So they might be doing deliveries and getting good outcomes, which some of those maps are showing, which is fantastic. That's what we want. But what we hear from the public and from industry is we don't have enough physicians. We have wait lists for you to get into an OBGYN to even for your prenatal care and then your follow-up. So again, this is one piece of information and data. You're going to learn a lot more about the Wyoming hospital landscape from Department of Health here in a minute. But you have to look at the whole picture on that. And that's just one piece of the data that came out of those mortalities. And we didn't have every hospital respond to the survey. It was an optional survey for them to fill out, and 15 is what we got.
Okay, Representative Ward. Yep, Representative Ward, go ahead.
Thank you, Mr. Chairman. So I'd like to reiterate and maybe expand on my previous comments. So what I'd like to see is increased freedom, that there's more freedom to the providers. So especially CPMs and nurse midwives, there needs to be a way for them to have backups. I have a feeling this situation would improve if they were able to have access to hospitals, to OBs who didn't refuse to work with them. And yes, even in Casper, we're seeing this problem where I have pregnant friends who ask my advice because they know my history. They want to deliver at home or because they have low risk birth, and they are more practitioners like CPMs and certified nurse midwives who can assist with all these low risk births, which is what the majority of birth is, because birth is not a disease. It's a joyful natural event. So how can we increase freedom so that CPMs, midwives have more room to practice?
Chairman Zawanitzer and Representative Ward, I wish I had a good answer for your question. I think that is part of the debate and conversation that we all need to have. I think there are lots of things within that question that I think are very physician specific. I think they can be very facility specific. And I think that the first place we need to start is finding out exactly what the barriers are within each of those locations. We did the survey here to just get a broad overview. But to Senator Bouchard's point, it doesn't go deep into that data on each of the facilities either. And I think that that's where we need to start. Who are our birthing hospitals, which we know, and then how do we have those conversations about to open other opportunities? And again, I think it becomes a philosophical question for many of our providers. And I think that that's where things get really complicated. But I think that's what we're all here to do. I think that's why you guys picked up this topic. It's why we've had a committee, is how do we get to the next step to really open up access for our residents of Wyoming, because it's really important. And we know if we don't have care where people can have babies, we're not going to be keeping our young people here in the state or bringing young people into the state if they can't have babies. So it's a really important question that I think we all need to wrestle with and dig into.
Literally bringing young people in the state. Really young people. Representative Clouston.
Thank you, Mr. Chair. So last week I got to attend a meeting with a bunch of physicians in Gillette. And we were talking about the OB problem, trying to recruit people to Gillette specifically, but they said a lot of the new OB docs were going to South Dakota. South Dakota has some limits on the amount of, lawsuit limits. I think it's $500,000 in South Dakota, right? That's the maximum that a physician could be sued for. Have we ever had legislation, are you aware, in Wyoming to try to address that kind of issue?
Ms. Davis.
Chairman Zawanitzer, we have an issue in Wyoming, and we need to be open and receptive to all of those issues that are barriers and figure out, do we want to solve them? And then if we do, how do we solve them? Because I think that's a really big thing. I was talking to another state that said they're not having trouble recruiting, and their laws in that are different. So again, we need to just really dig into why are people not wanting to do that here? And then we have to decide if we want to try to solve it. And if we do, then I think we need to be having those tough conversations.
Okay. With that, Representative Penn.
So thank you, Mr. Chairman, Ms. Davis. To kind of go off of what Representative Ward was saying a few minutes ago about how do we increase that ability, more autonomy, more whatever. Have we looked at all into looking at our Wyoming statutory requirements of what oversight is required? What are these CPMs, CNMs? What are they? What kind of oversight by a physician are they required to have? Outside of delivering babies, nurse practitioners in this state can practice independently of a physician. Have we looked at that?
Yep.
Chairman Zawanitzer, Representative Penn. Yeah, those are questions that we have been looking at. And And definitely asking, as you all probably know, the governor did an executive order just a little over a month ago to have all of our healthcare licensing boards to look at things like these questions of what is the industry saying are barriers? And then how do we overcome those? And is it in rules? Is it in statute? But really looking at some of those things that are prohibiting us for increasing access to care. So I think those are things that we also need to be looking at. We haven't dove deep into that yet. Like I said, this committee's been meeting for just about 9 months. We did the survey to start with, and but those are all things that we need to dig into and look deeper into.
Okay, we'll get you off the hot seat because there's a lot of people here to testify. Don't go too far. I'm sure you won't.
All right, thank you all.
Department of Health.
A quick question for Representative Ward.
Oh,
If that's appropriate.
sure. Representative Yin, go ahead.
Thank you, Mr. Chairman. Representative Ward, so I'm really trying to figure out, because I have some thoughts on how we could try to do what you're suggesting, but I'm really trying to figure out where in statute the midwife requirement for partnering with the physician is, and maybe Department of Health or someone else will be able to know the answer to that. So if we want
Hearing is that a CPM wants to take a client to be at their birth, but they can't find an OB to back them up. If something goes wrong and you need to rush to the OR, usually it's not a rush, almost never, to do a C-section, for example. There are very few OBs who want to partner with CPMs or certified nurse midwives. So, and we need more willingness to do that if we're going to increase coverage of care. I hope I sort of answered your question.
And maybe department or LSO could find for our next meeting. Are you gonna find it right now for us, Anna? Or if you start, we're gonna be here a while. So if you could find it, when we start talking about ideas to pursue on language to be drafted, that would be great. Representative Penn?
If I can just add on to what Representative Ward just said, that is the case. I know that to be a situation within our community, within the clinic where I work. I experienced that situation when I was pregnant with my baby. I had a nurse midwife who was able and ready and willing to deliver if I were to, have this baby on the weekend. And her overseeing physician was headed to Europe about the time when my baby was due. Were at that time 4 other delivering providers in our community and at this hospital, but none of them were willing to be the overseeing physician for her that weekend, or really at all. And so while we had the ability to cover it, we didn't have the ability to cover it.
Thanks. All right, Department of Health, welcome back. We love slideshows, but yours has lots of colors in it, so we're excited. Floor is yours.
Thank you, Mr. Chairman. Members of the committee, my name is Franz Fuchs. I'm Policy Analyst at Department of Health.
Hey, Mr. Fuchs, what's your official title?
Mr. Chairman, I'm the Chief Policy Analyst at Department of Health.
Okay, thank you.
Of all the analysts. Yes. Whatever that means. So, Mr. Chairman, our slide deck, we have some presentation slides for you. Slide 12 of our omnibus presentation. I think LSO broke it up into multiple presentations for your convenience. Slide 13 talks about the agenda. We have a very relatively targeted presentation. We want to talk, at the Department of Health, we tend to focus on what is the problem? What is the problem we're trying to solve? So we are looking at what is a maternity desert, and we are positing to you our perspective here in this presentation is just our perspective, is this is function here up here to answer the hard Medicaid questions for you. But also there may be expanded role. I think so Representative Clausen mentioned, malpractice insurance. Are there potential issues where the state could come in and try to help that issue? So that's just the last slide. We really split the bulk of the presentation talking about what is the problem, really, and we want to frame it in a very certain way. So the March of Dimes, when you look at Google Maternity Desert, this is kind of what comes up. The March of Dimes is the entity that sort of curates what is and what isn't a maternity desert. And if you look at their map, you can see they've They've defined the counties in red as deserts and the counties in orange as low access to maternity care. We wanted to offer a bit of a refined definition. This uses national data that's a bit dated, a couple of years old. And we wanted to add more recent data, more Wyoming specific data to kind of give you a more nuanced picture, which is the next slide. So on this slide, we have, Katie, if you wouldn't mind going back one more. On this slide, we are carving the counties up into what we're calling long-standing maternity deserts. These are counties that have never had a hospital that does labor and delivery. Weston Crook County, for example, there's never been a hospital there. People are there are used to going to other hospitals for care. So those dark brown ones we're calling long-standing deserts. The more recent issue we're seeing in the last couple of years are what we're calling the new maternity deserts, and these are sort of the orange counties. So looking at parts of Fremont County, Carbon County, and South Lincoln County. And these are by county subdivisions. So it's not, I think there are important differences between the counties. And as you all toured the hospital today, North Lincoln County, we would not consider a maternity desert. It's really the south part of this county that is important to focus on. And then we have a couple in tan that we're calling warning. These are just some interesting trends we've noted in the data that are a little bit concerning and may be worth further scrutiny going forward. And then all the red dots are the hospitals, both in-state and out-of-state, that have birthing, labor and delivery facilities. So why are they a problem? Why do we care about maternity deserts? Really, there's two major issues. One is health, right? There's increased distance. This is associated with increased severe maternal morbidity. And that has concomitant costs and with those healthcare outcomes, right? Transport, specialty care, those kind of things. The other argument is a little more philosophical and fuzzy, but there's sort of an argument for general economic viability. Just like electricity, water, sewer, you have to have basic infrastructure to attract a workforce, to recruit workers and build businesses. Healthcare and available healthcare, and specifically availability of a hospital or ability to have kids locally could be considered in that sort of basic infrastructure category. So there's a broader economic argument to be made for why it's that 3 hospital L&D units have closed since 2018. We believe that these closures are really sort of a symptom of a load shedding. So basically, when a hospital is experiencing financial distress, it's going to close these sort of elective sort of cost centers, right, that tend to be less profitable. So closures of L&D units are really a symptom, not necessarily a deliberate decision by the hospital to just shut off label and delivery. It's really a symptom of a broader financial problem at the hospital. And the reason there is that they are relatively high cost. You have to have a lot of nurses on staff. You have to have locum tenens or physicians, right? You have to have you have those 3 OBs that are ready to come in at a moment's notice on shifts. And those are fixed costs, right? You got to have that regardless of how much volume you have. So if you have low volume, it's kind of hard to cover those costs on the revenue side. There's also the lower margin, right? So on the revenue side, maternity care generally is less lucrative, right? So compared to swing bed, a nursing home, or elective knee replacement surgeries.
Well, yeah, Reverend Ward, jump on in.
Thank you, Mr. Chairman. I'm sorry. I thought I heard you mention they have to have 3 OBs. Is that right?
Mr. Chairman, Representative Ward, so 3 OBs to cover a reasonable amount of a 24-hour period. So each OB having an 8-hour shift. I think you can go lower than that, but there's sort of a minimum practical floor of the number of doctors required to cover a 24-hour day, be on call. If you go below that, it puts a lot of stress on those remaining doctors and physicians, and that can cause a lot of burnout. So we typically see 3 as being a relatively practical floor for a hospital to maintain.
Go ahead, Reverend Ward.
Thank you, Mr. Chairman. Mr. Fuchs, but that's not in statute, right?
Mr. Chairman, I don't believe so.
Thank you.
I don't think it's in statute, and we have some hospital folks here, but I do think it is I don't know if it's a CMS requirement. There's some type of requirement. You have to have so many as a certain profession to be able to operate that type of division. And I'm sure we can call up someone, but
Mr. Chairman, it's probably in the conditions of participation with Medicare, Medicaid, if I had to guess. There may be some standard. I don't know if it's 3, but there's probably some number.
Thank you, Mr. Chairman. So that is the type of law that I'm suggesting we need to change. Because if we're if that's an obstacle to keeping OB wards open, we need to address that. Wouldn't you agree?
Mr. Chairman, Representative Ward, the Medicare and Medicaid conditions of participation are federal, so it wouldn't be under state statutes. And I think there's probably a good reason to have those numbers. I think there are, to be on call 24/7 for a single provider, I think.
And state Medicaid agent with the Wyoming Department of Health. I was just informed by my phone a friend that 3 is best practice. And so that's not a statutory item to change. So I think for the purposes of this conversation, I'm really just intended to help illustrate what that sort of OB service or offer at a hospital would look like.
Mr. Chairman, just a couple other notes on the bottom about higher levels of care. I think it's obvious we don't have, many advanced NICUs, a lot of babies that require that level of care go out of state. So when you look at hospital delivery trends, there's a little bit of an eye chart. These are all hospital births that reported to vital statistics from 2016 to today. So I think, we put the dots, that's basically the count of births by every single month. And then we have the red trend line, which is sort of the average number of births per month. And I think the interesting points to note are, one, there's sort of a declining trend generally across the state. I mean, I think there's fewer women of childbearing age in our population having fewer babies. So there's a broader negative trend generally. You can see the closures of the L&D units in Carbon, South Lincoln, and Riverton, respectively, as the red X's. You can see the L&D volume essentially dropping to nothing. There may be, I think, 1 or 2 births happening in an emergency room, which is why you kind of see a couple dots past the trend there. But generally speaking, that's kind of when the births tapered off and dropped off completely. And then I think what's also interesting to note is that so if you look at Carbon County, for example, their previous average was around 6 births per month. But then there's other hospitals like Torrington, which would be very comparable, Johnson County, and even hospitals with lower volume, Washakie, Platte, that have very stable trends in births. So I'm not sure volume is 100% the reason for things. I think a lot of it has to do with revenue and has to do with management of the hospital and decisions that were made by that management, not necessarily the fundamentals of the number of babies being born per month. And then you can see of note, I think finally the orange real quick, one back, Katie, thanks. On Lander, we've noticed a bit of a concerning decline recently in the last year. And this is kind of where we put Lander on the warning map, that part of Fremont County, just because their previous baseline was around 35 births per month, and that's gone down significantly to 20 just recently. So a little bit of a cause for concern there. A lot of those moms you'll see in the next slide are actually going to Thermopolis, of all places. So when we look at the maternity deserts, we ask, okay, where are the moms going in the absence of a hospital, right? And we're now looking at Medicaid data. So we don't have we're not looking at the vital statistics for all births. It's just purely Medicaid moms. And you can look at sort of the percent of going to Ivinson. Places like Baggs never went to Laramie to begin with. They tend to go to Steamboat Springs. But aside from that, that's kind of the picture in Carbon County at the moment. In South Lincoln, so we're looking at you can see Kemmer, the closure there, the green curve has gone down since 2022. That's largely been replaced based on geography. So certain places, closer to Rock Springs are going there. Cookeville, you can see, is going more to Evanston. But, this kind of indicates where over time these moms are, as a sort of market share mechanism, tend to be going to other alternatives. And then finally, just an example in the Northeast, what was interesting about this was that it's been relatively stable, but the share going to Gillette has actually dropped off a little bit recently. So if you look, for example, at Sundance, a lot more moms, or specifically larger number of moms, are now going to Spearfish in South Dakota. So we thought that was an interesting trend. We didn't know exactly what's going on there, but it may be worth asking the hospital folks from that area. Bighorn, as always, again, this is one of those long-standing deserts. So the trends have been relatively stable. You tend to go where the closest hospital is, either Powell, Billings, or Cody. So that's on the hospital front. We have a couple more slides on providers. So This kind of points to Senator Bouchard's point. On a statewide basis, if you really look at us compared to the national average, we are fairly comparable, right? So we have 47 OB and midwives per 100,000 women 15 plus, and that's compared to 46 nationally. So we are not below average. We're 21 out of 50, and that ratio has been relatively stable. There are, of course, other providers that do deliver babies. As Representative Ward mentioned, there's midwives. We have family medicine physicians in Hot Springs County. Actually, a lot of the smaller counties rely on family medicine docs. So it's not just about the OBs. But I think the main problem here that we want to point out is that it's really there are huge disparities both across counties and within certain counties. So it's really, Teton County, probably no real issues with doctors per capita. I mean, I think they have more doctors per capita than New York or Massachusetts. It's really counties like Bighorn that are really suffering when it comes to physicians per capita generally. And then you can see on so slide 24 shows this visually. The official data is from the Health Resources and Services Administration. Sorry, back one, Katie. The HRSA account, those are those black dots. And so this is the ratio of providers per 1,000 women of childbearing age. You can see that ratio measured back since 2005 has been relatively stable and increasing slightly, right? But we wanted to augment that with a little bit of our own data. We added from a Wyoming Medicaid perspective, though, and our ratio is around 0.9, and it's been relatively stable as well. And then here's just a table of those 15,000 deliveries since 2016, kind of by type of provider, which are the columns. So you can see midwives at the first column, emergency medicine, family medicine, and so on. So non-nurse midwives are considered in the other category. That was recently opened up to Medicaid, I think last year, if my recollection serves. And so we have very few of those non-nurse midwives that have been Medicaid providers, but they are listed in the other column. And I thought what was interesting about this is certain counties like Hot Springs rely far more on family medicine docs and have a fairly healthy, I think they have 4 or 5 family medicine docs who do pretty good work in that particular area. So it's not just about the OB, although they of course are the majority. There are significant other provider types that do provide services. And then back to the disparities across counties. This is another eye chart, and I apologize for these. We were trying to cram as much stuff on these as possible, just for reference. But this kind of shows the disparities across counties, and we've highlighted the ones that are real, of concern. With, for example, Niobrara having no providers. The line there is the population of women that are between 15 and 45. So that has, for example, Campbell County, you can see that kind of has peaked and is going down now. So that might explain some of the drop in deliveries is just based on a population basis. The dashed black line is the 3 providers baseline that we talked about, had that discussion earlier. So that's sort of a recommended floor for the number of providers you'd like to have in a county. The black circles are the count of OBGYNs per the Health Resources and Services Administration. And then the red dots are the Medicaid providers. So we're looking at a lot of stuff here, but I think that, just to point out, counties like Crook, Bighorn, Sublette, Weston obviously have almost no providers, right? Counties like Fremont and Campbell, you can see a concerning trend in a decrease. So the dots, you see the dots going down, right? Both in Fremont and Campbell County. And that's kind of why we put them on that warning map, is because not only are we seeing issues in the hospital trends, but also in the provider counts.
So I guess in your professional opinion, Wyoming's always been a rural state. We've always had issues in this area. Is it more we actually are having a crisis all of a sudden and things are flashing red, or is it more we've probably always had these concerns and there's just a lot more attention being paid to it because the national level, I mean, the nationwide mortality rate is high,
warranting further investigation.
That didn't used to be there.
Correct. And I think particularly in the new maternity deserts, right, to go back to that map, those are kind of the areas and the warning ones I'd be more concerned about. Crook County, I don't think anybody ever expected to have a hospital that delivers babies in Crook County since time was time. So, I mean, no offense to Crook County, it's just very, very small, right? And they have resources nearby in other counties and out of state. So that's not the issue. I think the issue is more these new maternity deserts and the possible warning signs in these other counties that we'd like to highlight.
Representative Hornock.
Thank you, Mr. Chairman. So back on that map, and it probably correlates with the slide that you've got up, but explain a little bit more about what you would consider warning and how it got to that point, because you've got Gillette and Pinedale, I assume, on that map with the red dots, and they're in warning states, but they've got healthcare systems in those places. So I'm just curious how you would classify something being a warning that you think something needs to be done.
So Mr. Chairman, Representative Hornock, I would say there's an extremely fuzzy, like just looking at the data, gut feeling about, this is a county we should keep an eye on. I colored it kind of beige to make it non-threatening here, but I wouldn't say that, we need to have our hair on fire. We just thought there were some anomalies in the data, particularly the decrease in births in Lander and the hospital side, as well as the decrease in providers in both Lander and Campbell County. It's worth trying to figure out what's going on in those particular counties. And that's just a very recent, last year type deal. And so, yeah, that's, it's the rest of Fremont County, I would consider a maternity desert because Riverton, stopped doing births back in 2016. But even Lander is now seeing sort of a decline, right, from around 35 a month to almost 20 at this point. So I don't want to be alarmist. It's just something to note for the committee that, this might be worth further scrutiny as to potentially new maternity deserts that may be emerging.
Thank you, Mr. Chairman. And could you explain with this, basically, it looks like the problem is in the lower population counties. So are all the graphs and everything you've looked at, does it correlate with the population per 100 people per whatever? So that
have always had very low populations, right? Probably our least populated areas. Our major, a bigger concern for us would be the newly created maternity deserts in relatively larger or mid-sized counties. Carbon is, Rollins is a fairly large city when it comes to Wyoming standards, right? That's a concern because not only is it a larger population, but it's something recent, right? So there's a lot of people that moved to Rollins or may have set roots down there that expected that service, and now it's gone. So it's a change from sort of the past status quo. Whereas people that have lived in Crook County or Weston County have never had a hospital. So it's a little bit of a different, right, situation, I think, for them. I think also we would also point out that Campbell and Fremont, also very sizable counties by Wyoming standards, are showing some concerning trends. And that's worth keeping an eye on.
Thank you, Mr. Chairman. So I want to focus just on one county. So Sheridan. When I look online, I see the tour of their birthing center. And it looks like a really good commercial. It looks really high tech and state of the art. So I'm trying to figure out, are we really looking at these numbers right? Because it looks like they have a facility there. And I mean, there has to be some real specific things we could ask and them specifically. I'd love to have them in here in the committee and say, hey, what's going on here? We have an advertising video that says we're state of the art, we're the best place there is, but yet we're up on this map here. So
Mr. Chairman, Senator Bouchard, so Sheridan actually does fairly well. They're in the white on the right next to Bighorn County, and on the map with all the counties, or sorry, all the eye chart with all the county graphs. This is slide 26. Katie, if you wouldn't mind. Sorry for jumping around. Sheridan has a fairly healthy provider base. You can see on sort of 2 up and 2 over. or sorry, I guess, yeah, one over from Uinta, right? Sheridan's provider base is certainly above that 3 threshold, and it's as a ratio to the population, it's actually fairly healthy. So I would say Sheridan's one of the healthier counties with OB.
Let's start with Representative Penn, just because she's sitting closer. Go ahead.
Thank you, Mr. Chairman. I think I can comment a little bit on what's happening in Lander, and I think it's a multifactorial issue. We had one provider who had a major health event and didn't really come back from that. We had other providers, it was burnout, and they've been doing this for a long time and feeling like other providers weren't pulling their weight. Some part of it was concerns with support of the hospital or management there at the hospital. And so I'm not sure that this is something that, at least on, that art and Fremont County, that we can say, well, we can address this as a committee, because there's lots of things going on. It all kind of happened at once, unfortunately, and then all of a sudden you have this drop in providers. There are efforts underway to address that, hire, they're interviewing and they're doing those types of things. And then, as we heard in our tour today, the reimbursement is not great because the medical malpractice to deliver babies is astronomical. And so there's a lot of factors that are playing a part here, and why we're facing what we're facing: low numbers and high operating costs and malpractice and burnout and all these things. It's a conundrum, to say.
True. Senator Hutchins, do you have a?
Yeah, Chairman, I appreciate that. When you look at the new the sovereign nation, is that
Browns?
Mr. Chairman, Senator Hutchins, I did not include the Wind River Reservation. I just have it, the county subdivisions here. Yeah.
Okay, carry on and speed up.
Yeah. Mr. Chairman, so that brings us, I think Representative Penn's point, we talked about the problem, a little bit, but we want to kind of frame it. We want to, say, okay, this is primarily a hospital viability problem. It's not the only problem. But we see it as sort of the main, if you're trying to eat an elephant, you have to start one bite at a time. Right. And so this is our perspective. Certainly, I'm sure a lot of people here that may offer different perspectives. But we see hospitals as, because they are the community anchor for this, they have this infrastructure, the nurse staffing, the support for perinatal care if things go badly. But they also recruit and retain providers. So OBs, they need the workshop of the hospital to be able to, earn the revenue of delivering babies. And so without that hospital, there is no workshop. And so hospitals, and kind of goes both ways. Hospitals also recruit and retain that workforce and are required to some degree. So again, as we mentioned, the L&D closures, we see that as a symptom of broader hospital financial stress, and not necessarily as the state. We are also somewhat responsible. We are a large payer for a lot of these births. 30% of births are paid by Medicaid. And you can see here that this is according to our cost report that we provide DFS when they're chasing down the deadbeat dads. $7,500 per birth includes both the provider and the hospital. That's a global bundled rate that has how much it costs Medicaid per birth.
So 20 years ago when I started, we were close to 50% of the kids born in the state on Medicaid, and we've done a lot of work to get that number down. Has that been I mean, it saved the state a lot of money, but has it been a negative thing then for our hospitals based on, is it the Medicaid rate more? It's not just that they're born on Medicaid, it's because Medicaid doesn't pay the same amount. Is it because we don't have Medicaid expansion? Would that make a difference here? Give me some more on that.
Mr. Chairman, I don't think Medicaid expansion really factors in, just because these mothers would be eligible for Medicaid based on income, and there's no gap per se. This is really just about the rate paid per birth, right? So if your alternative as a hospital is to do uncompensated care, then Medicaid is great because you're getting paid something. If your alternative is a private pay patient, it's not so great, as you can see from the comparison here, right? So $20,000 for that bundle, right, paid to both the provider and the hospital, compared to $7,500. So when you have a high fixed costs and this cost is the same regardless of the payer source, this affects your margin significantly. And that's really the issue that we could potentially, you know, we do play a role as a state payer that we want to note here. There have, of course, have been higher costs as well in the hospitals, right? So post-COVID, there's been a huge shortage in nurse labor. I think we're all aware of that, with both, I think the governor's office mentioned that, you know, the reliance on contractors and such, as well as provider recruitment. But we also want to point out that it's not all, at the very bottom, we do believe there's a hospital and management challenges has really caused some of these issues. It's not just about the fundamentals. There have been, you know, potentially poor decisions made by management that have caused some of these situations that lead to the labor and delivery closures. And so what is the role of the state? I think, you know, Representative Penn, your point is well taken. Is there a role of the state? You know, if the problem is multifaceted, you know, maybe it's not, maybe it's the role of the county, maybe it's the role of the local city, maybe it's the hospital role. We want to point out, you know, we do have a current role, right? We are a payer. There could be, you know, some options for our current role. We could increase Medicaid payment rates, try to bring it closer to parity with at least Medicare. That, of course, is a cost, and that's a dollar figure you all as legislators would have to appropriate. There's other options there, for example, helping distressed hospitals with management and financial operations. There's also the idea of malpractice, right? Some states like Nebraska and Oregon do sort of risk pooling and offer malpractice and reduce the risk of malpractice to their providers in exchange for participating in quality improvement activities that are governed by the state. And then, as the governor's office mentioned, regional coordination. And all of these roles of the state, you know, it really takes us from a sort of status quo, you know, where we are now, to different directions, whether we're exerting more control over the hospitals or spending more money, or the reverse, spending less money or exerting less control. There's different options this committee could consider. But we hope at the end of the day, this presentation has given you some idea of why we think the hospital viability is really the first problem to be looked at. So with that, Mr. Chairman, I'm happy to take any questions.
Representative Hornak.
Thank you, Mr. Chairman. Question on the last slide dealing with payments. So I understand, and I think you alluded to this a little bit, but you know, I'd like a little more clarification, because hospitals provide, I don't know, 50, 100 different services, and childbirth is one of those services. So you have a hospital like in the town we're in, which is a great, you know, we toured it earlier this afternoon, where they deliver a handful of children. The amount of money they get paid to do that service clearly does not pay for the entire wing of that hospital and all of the staff and all of the people involved. However, other wings make up the difference. So, you know, me as a business owner, I might buy a piece of equipment, and that piece of equipment gets paid off because I do 2 or 3 jobs that pay for that piece of equipment. I might never get another one of those jobs, and so the equipment doesn't pay for itself, but the other work that I do kind of substantiates me owning that type of piece of equipment, or whatever the situation is. So I mean, it's a little bit, yes, not every maternity ward will pay for itself, because we just don't, I mean, people like the fact that we're a low population state. And so there isn't that monetary ROI on the business end. So I'm curious if you took that into consideration, or if you're just giving us the raw data of a delivery as this many dollars, and you can pay for
Medicare, you know, kind of nursing home is a moneymaker. Orthopedic surgery, elective procedures, that's a moneymaker, and that pays for that other stuff. That's absolutely correct. All we're saying here is that the disparity between Medicaid and what private pay pays on the revenue side reducing that gap slightly could make it less of a loss leader and help some of these hospitals keep their financial picture in better shape. It's certainly not going to make it profitable.
But you could give us a list of what other states pay for delivery. Is it a separate payment for delivery rate on Medicaid? And do we have that information readily available? You could get it by the next meeting, Mr. Grossman.
Mr. Chairman, we have an existing benchmark report that we do on an annual basis for essentially all Medicaid rates where we look at the region. For I think to the second part of your question in terms of how we pay for that, just on a general basis, it's the prenatal care and the delivery payment that would go to the OB. That's all bundled, and then all postpartum visits are billed on essentially a fee for service per claim basis, if that makes sense.
Yeah. You'll find me some creative way to do an upper payment limit on it, if I ask nicely.
You know that, Mr. Chairman, that's the burning topic these days. So we'll see what we can do.
Representative Ward.
Thank you, Mr. Chairman. So instead of increasing government, which is what we're doing by suggesting we increase Medicaid reimbursement, how about we consider that if you're an obstetrician who receives any kind of government funding, you have to partner with at least one CNM, certified nurse midwife, or CPM. How about that?
Is that the government forcing you to partner with someone you might not want to, though?
If you receive government funding.
Thoughts on that? I mean, as an option, any issues from regulatory that you can see that would be a concern?
Mr. Chairman, I'm not sure. I think we could probably, subject to federal approval, come up with additional, enrollment conditions for doctors. I think the risk would be that some would just not enroll in Medicaid at this point. They may not decide it's worth it. For whatever reason, I don't know why they are choosing not to do this, but if it's too onerous and Medicaid is not a big part of their paycheck, they may just choose to discontinue that entirely. That's probably the biggest risk I would see with this.
Mr. Chairman, if I may, I think and Representative Ward, to your question, if I'm interpreting what you're getting at correctly here, that's broader than Medicaid. I understand we started with the rates there. So I don't even think
Well, a little bit, Mr. Chairman, thank you. I'm not sure if you would have the answer to this. I'm just curious because when I've done a little bit of research into adoption and the adopting a baby, it's a $40,000 hit because you're paying for the medical services of the adoptive mother and things like that. I mean, when Medicaid only pays $7,500, private pay is $20,000, but yet somebody has to pay $40,000 to adopt a newborn. Do you know why there's that kind of a difference? I'm sorry, it's not necessarily related. It's a little bit related, but the cost wise, it is what I'm concerned about. Why is there such a difference in the gap in funding?
If you know.
Mr. Chairman, Representative Hornock, I don't know, but I think there may be some people that I could throw under the bus. I thought I saw Roxanne here from DFS. They may be able to speak to adoption more broadly. She might know.
We'll bring the bus to her in a bit.
Yeah.
Go ahead. Other questions to the Department of Health, Representative Yin.
Mr. Chairman, thank you. Franz, how many births are Medicaid births in the state?
Mr. Chairman, Representative Yin, it's 30% as far as the total number. I think it's around 3,000 a year, but lead,
Yeah.
You're good. You have a report.
Mr. Chairman, Representative Yin. So first of all, we have a Medicaid birth report that tracks these numbers going back year on year. We can follow up and send that to you. It'll help show the trend that the chairman also pointed out of how that's decreased over time. This is just a number I've jotted down in front of me, looking at our most recent count of pregnant women who were served distinctly. So keep in mind the asterisk that it might not all be a one-to-one in terms of number of births. But in fiscal year 2023, we had 5,569 pregnant women that were served through Medicaid. There's a whole host of factors into why that number of births would be lower. But just to give you some semblance of where that number is, I think the 3,000 or so that you heard from Franz is a good ballpark. And I might just be filibustering long enough for Franz to have found that specific answer.
Representative Munin, go ahead.
So, Mr. Chairman, I mean, I think the reason that I'm asking is just to get a sense.
And at the last minute was 2021 data, and that was 1906 Medicaid births out of 6,235 total births in the state.
Okay. Further questions for the Department of Health? Not yet. Great. Don't go too far. Well, some of you are leaving, but don't go too far tonight. Women's Foundation, you're closest. So if you want to go next. I don't see any other state agencies in the room. And yeah.
And we submitted some late information too after attending the same webinar that Ms. Davis did. And so I don't know if I think they've got me on the agenda to come up a little bit later, but I'm happy to share that as well this go round. So
No
let
time
me
like
know.
the present.
Okay. All right. So I am Micah Richardson with the Wyoming Women's Foundation, and we work for economic self-sufficiency for women and opportunities for girls. And today I will be presenting on just a few items, most of which create opportunities for partnerships and provide some interesting options for addressing the maternal health desert and maternal health generally. And kind of a lot of times when I'm thinking of some of these that we're presenting, we aren't, in the healthcare realm. And so I think about a little pitch for the what Jen presented on earlier this morning. I feel like a lot of these would work right in there. So first one are the mobile health units. So these would provide resources that would go to folks in communities rather than women having to travel to centers. So one way we envision this rolling out is that the Department of Health could apply for funding to receive a Health Resource and Service Administration, so a HRSA grant, which could launch the program. This has been done in other states, quite a few other states actually, and provides that opportunity to launch a program like this. The Department of Health could also be the lead in ensuring the program has a licensed provider who is able to create orders for nursing staff, students, and others who require those written orders. So in talking with the university, they were interested in this idea, but noted that through their program, so let me backtrack a little bit, often in this model, they will use nursing students to help provide some of these services in communities. So it's one more resource. But in order to provide some of those services, they need orders. And so that could be a role that the state helps with in terms of having someone who could write those orders. And so in looking at this, what would the legislature's role look like? Task the health authority to service, and it could be launched in our kind of envisioning of this as a pilot program, maybe in one of these communities that is really feeling the hit on low resources. And so after evaluating it, looking at ROI, seeing if access to care did improve, the legislature could look at expanding the program to other counties and thinking about how to sustain it and see if there might be funding that could go toward it, or if there's additional grant funding that would be available. And so that is one of the ideas that we had kind of mulled over and thought might help again get those resources out to communities rather than having women have to, drive these distances. So just one option. Any questions?
Questions? Seeing none yet.
Okay. The next example that we talked about was developing a midwifery track at the University of Wyoming. and or the community college system. So as Wyoming struggles to keep OBGYNs, exploration of additional options to increase number of midwives and add sustainability to the OB network would be kind of the opportunity here. Again, in speaking with UW, there was interest. However, the folks in the nursing department noted that it might be wise to see how the physician assistant program rolls out first. They've just launched this, and they have a very, in-depth understanding of how that all happens. So a new licensing program would require a multi-step process. They would be able to talk to this far better. I would only be pretending that I know all of the ins and outs of this, but a multi-step process, and it would make sense to understand those hurdles and setbacks encountered with that PA program before you maybe jump into starting a brand new program with the midwifery program. But ideas in the interim. CU, Colorado University, utilized HRSA grant funding again. So utilizing these funds to launch a program like this. And perhaps there would be an opportunity to create a partnership with CU, utilizing the WICHE funds and getting students down to participate in that midwifery program that is already being in place in Colorado. So that is again a place that could be explored with the health authority, or so as I come to this again, that seems like a great place for me, because as a non-medical person who is not in the Department of Health or Department of any of these departments, I did share some example legislation about what that could look like at the bottom of that piece.
So far, so good. Art Center Docs there.
This program is already being used in Colorado?
Yeah. So they, CU applied for a HRSA grant. Boy, I think this is their second year. And they have, from the bit that I've read, and I've tried to contact the nursing staff at the university to learn a little bit more about this, but they have 5 to 6 potential folks who are practicing to be nurse midwives grow through the program each year.
So nothing further on that one.
Okay, moving right along. Because just thinking about time, one of these that I had put in the handout is really not legislative that you would really need to play a role in, but just would provide more resources to hospitals. So I am going to jump over that piece and talk about some midwife workforce training and doula coverage. And so just a little bit of information that the findings show that doulas can be an effective strategy to increase attendance of health appointments, improve healthy birth outcomes such as preterm birth rate, low birth weight, and NICU admissions. They foster nurturing and responsive parenting behaviors and increase breastfeeding initiation. And so there are a lot of ways that doulas could play a part in empowering women and helping them. As Representative Ward had said earlier, they do not deliver babies, but provide a lot of support. And so those outcomes are what we have looked at. And one possibility that you could also look at is adding coverage to the Medicaid plans for doula care. So those who are already on Medicaid, you could just allow doula care to be included in that payment process. And so those doulas would start to get paid for their services. And in seeing what that has looked like in some other places, there has been a advisory board. I don't know the number of doulas in the state, and perhaps Representative Ward does, but that would kind of think about what the core competencies that would be required if something like this were to move forward. So that's just one more option.
Go ahead, Representative Ward.
Thank you, Mr. Chairman. So I just wanted to emphasize that most doulas are hired by the parent. They see more freedom than paying, Medicare for doulas. So I'll ask the same question to you. How can we increase the partnership between CPMs, CNMs, and OBs?
And I will give through you, Chair. I will give the non-expert, non-hospital medical view. And, I think one opportunity, which would not be legislative at all, but would be to find areas in the state where it is working well, where those relationships are working well. And could there be some sort of education amongst, providers and doulas to just start sharing, like, what are some of those issues and concerns that folks have? Are there opportunities to just open up those lines of communication? That's all I got though for you. I don't know.
Good there. So other states, from what you know, do reimburse doulas?
There are some states that do reimburse doulas, and I do not recall if I included that chart or not, but I'm happy to get the information to y'all if you're interested.
All right.
Thank you.
Thank you. We'll think about some of those suggestions on that handout. Next up. Anyone else here wish to testify on maternity care, maternity deserts, ideas on how to improve Wyoming? Ms. Bush, welcome. You could even bring Mr. Boley with you if you want.
I'm bringing it.
Okay. Welcome, Sheila.
Thank you, Mr. Chairman, members of the committee. Sheila Bush with the Wyoming Medical Society. I was going to give a little bit of history on the physician statistics around shortages. I recognize it's 5 o'clock, so I will spare you that. I could probably email it to you. I think one stat in there that is probably important, or maybe a couple of them, the American College of Obstetrics and Gynecology projects a national shortage of 9,000 obstetricians by 2030. Another, I think, important comment, because I'm going to talk a little bit about the role of family physicians in maternal health in the state. And so in the 1980s, according to the American Academy of Family Physicians, 43% of family medicine physicians participated in maternal care, delivered babies. And in 2021, only 15% of family physicians across the country reported delivering hospital privileges, abiding interprofessional relationship stressors with OB-GYNs. So I think that's a really fancy way of saying there's tension, as I mentioned this morning, between different specialists within the healthcare system. And not all OBs appreciate or want that complement of a family physician component to delivery. So I think that's that barrier. Maintaining adequate volume for competency, lifestyle limitations, work-life balance concerns, reimbursement, as well as challenges in finding a family medicine residency program with OB fellowship or OB curriculum training. And so I was going to first, before I offer some solutions, I was told to definitely come with some ideas for solutions and not just problems. And so I will do my best to do that and do it quickly. But I do think as we get into this issue, there are at least 2, if not more, kind of separate conversations that are happening, and both are incredibly important. One is maternal mortality and infant mortality, which the United States is growing and not in a good way. We're getting worse that way. And the other is just simple access to care in the state. And I think some of the solutions can potentially address both of those, and some of the solutions may not. In fact, some solutions may work in some ways encounter or contradict the efforts to address the other. And so it may be important for the committee to really narrow the focus into what it is that we want to be addressing for the rest of the interim, and where we want all of your partners here in the room to be directed in the research that we do and the conversations we have with our membership, so that we can be as helpful as possible. So in solutions, We believe, recruiting and retaining the existing physician workforce, medical malpractice is an issue. And tort reform came up earlier. The last time this state meaningfully discussed tort reform was 2004 when it was put as a result of a special session and then put on the ballot. It narrowly was defeated, and it really hasn't come back up since. Other states around the country will provide some sort of subsidy, especially to OBs or family medicine physicians who will do OB. Family physician medical malpractice premiums are in the $20,000 to $30,000 range if they are paying those themselves, which is not always the case, especially in our state. If they add that rider for OB, those jump to $90,000 and $100,000 a year for the malpractice premium. And so that's obviously a barrier. Reimbursement, 2007, maybe 2008 timeline. But as far as an across the board intentional conversation around physician reimbursement in Medicaid, they've taken 2 big cuts, but no increases. And I think that it's probably time we have that conversation. We would really like to identify and remove those barriers to family physicians practicing full spectrum OB across the state. Not all of those barriers listed in that national data are necessarily barriers here, but I think that it's worth getting into that. And then when we talk about training new and future physician workforce, I'd like to talk about obstetrics fellowships at the University of Wyoming Family Medicine Residency Program. My research showed that there are only 18 family medicine residency programs across the country who train an OB fellowship. They're very competitive. They're hard to get into. In conversations with our residency and OBs practicing in Cheyenne who have the family physician residents train with them in their OB rotation, we each year have a handful who are really interested in wanting to go into OB and then can't. They either apply to those programs and can't get in, or they financially can't afford to go, or for, it's a myriad of things. And so I think there's a real opportunity, whether that is a version of WWAMI, but in residencies of, if you're a Wyoming family medicine resident, either we build on an OB fellowship to our program here, which I think is an opportunity, or if that's not feasible or realistic, something similar to WWAMI, where if our residents go out to an OB fellowship, if they return to the state and practice, take care of our patients here, we reimburse either the residency that or the fellowship program that they go to, a portion of that salary. They're paid a salary when they're in fellowship. So the state of Wyoming could partner with some of these residency programs to address that and incentivize accepting Wyoming residents. I think there are some opportunities for public-private partnerships that we could go into. And then finally, I think data collection is really important. All of these conversations, I think the more information we have, the better data we're able to collect, the better informed the conversation can be. And so I'd like to talk about sort of, do we have all the data that we need? And what data is missing that would be helpful? And so with that, I'll stand for questions.
Thanks. And if there is, what does that look like? How much time? Is that something we can incentivize our current family practice physicians to say, we'll cover 6 months more of training to have a basic level? And I don't know if malpractice, when that comes into play, what that looks like, but any more discussion on that?
Mr. Chairman, great question. And it's more complicated than it feels like it should be. So when I've asked that question, I've gotten a host of different answers. And I think the way you can explain it maybe is there are different tiers. So initially, a medical school graduate goes into family medicine, they match with a residency program. Not all residency programs have an OB curriculum. So in some, it's just not even available. Our residency programs here in the state do have a residency or a OB component. So they do rotations through obstetrics, deliver babies in the hospital, et cetera. However, without an OB fellowship, which is like that fellowship is that enhanced certification. And that really is the benchmark, especially for working in partnership with an obstetrician. Obstetricians have an expectation that family physicians, if they're going to be delivering babies in these rural communities, that those family physicians have an OB certification that comes through that fellowship program. So I don't know if I think the fellowship is what you're asking about. That is what that certification is. Is that helping? Does that make it worse?
No, I guess my question then is for insurance, because I mean, medical malpractice rates in this area have to be part of the conversation. Does that credentialing certification help in that world and would be enough to prevent liability? I guess that's the second part is, yeah, they can have the skills, but is that enough to not up their malpractice across the board or mitigate it in some way? And I know you probably don't know off the top of your head, but if you could look into that for our next meeting and maybe information.
Yeah, Mr. Chairman, I will say, I will look into it and try to get more information. And I think Mr. Boley has some information also from the hospital perspective, because many of our hospitals are the ones, especially for employed physicians and providers, they are providing that malpractice coverage. But what I would say is, as long as you're delivering babies, that rider is, a physician wouldn't go in and deliver a baby without that malpractice coverage. They can. It's not a state law. They're not required to have it. But we don't have physicians who go bare that way, or not many. If we have any, I don't know about it. And that
Maybe other states have done it to subsidize that cost. Like, I don't want to, I mean, personally, just direct pay hospitals or physicians, but indirect ways of saying, yeah, there's a way that it's in the state's best interest. We will help you in some respect to cover that additional premium. I mean, is that a possibility that I don't know if have you talked about with your doctors?
Mr. Chairman, yes. And there are other states who do it. I know the state of Oregon comes to mind. I think Oregon will help subsidize the rate of malpractice premium costs for physicians who deliver babies if they are in certain designated rural areas. So it's not across the board, right? So Oregon does have a model for this, and I've heard really good things about it. And I'm happy to look more into that if you'd like.
And bring it to our next meeting. That sounds,
Happy to.
I would be happy to see it. Other questions for the Medical Society? Representative Yin.
Thank you, Mr. Chairman, Ms. Bush, and I'll Mr. Boley, be aware I am going to ask you a similar question. There was a op-ed penned by a WWAMI student who said that the reason that they no longer want to be an OB/GYN in Wyoming is because of our abortion law, and that it creates uncertainty around the full range of reproductive health care, as well as, there's a 10-year prison penalty for it, right? So have you heard concerns from other doctors? And when we get to Mr. Boley, have hospitals heard concerns when they've tried to recruit that penalty and that those laws are hurting recruitment?
Mr. Chairman, Representative Yin, yes, overwhelmingly. I think the answer to your question is yes. But maybe not for all of the reasons that everyone might think. I think that the laws that have been passed recently create a lot of confusion, and they undermine any sort of predictability and insert the legal system in a really strange way into medical practice. And so the majority of the concerns we hear are about those initial situations where a family and a mom very much wants that pregnancy and finds themselves in a really tragic space, and they need life-saving treatment. And the debate and the consternation that happens among medical professionals about what they're allowed to do And if they look at the letter of the law, have they met abortion law? The one that is stayed currently, but the abortion law is, it does provide for life of the mother, but it doesn't give any detail or clarification around what that means. And so we get a host of questions to our legal counsel and to us about what is the expectation? What constitutes life of the mother? Is it a percentage chance that she'll turn septic today or tomorrow, or do we have to wait until she's a certain level of maybe their medical insight and experience tells them she's absolutely going to be septic and we should do these things today, but she's not septic enough, or we don't have enough symptoms to indicate that that's where this is headed. And so to protect themselves from being in the jail cell, they wait. And that costs moms a lot. It's really sad. And so I think Wyoming would be in really good standing to take a close look in a thoughtful way with respect to the fact that, the legislature has spoken about abortion, but there is this whole section that maybe lives outside of the intended consequence of what was maybe envisioned with those laws versus what also came with some of that, and some of that life-saving treatment that now has come into question.
Okay, we're going to here.
Thank you, Mr. Chair. How long does a OB doctor go to medical school for?
If you know.
Mr. Chairman, Representative Trujillo, well, all medical school is the same amount of time, so that's 4 years. So basically you have 4 years of undergraduate, you have 4 years of medical school, and it's at the end of that 4 years of medical school that they choose a residency. If they go into obstetrics, I believe an obstetrics residency is 3 or 4 years, and then if they fellow beyond that, so if they go into obstetrical surgery or a myriad of other things, they can fellow beyond that residency. So then you get into another, sometimes 3 to 4 years.
So estimate 4 to 8, 9 years in medical training and school.
A little more than, it's more than that. Yeah, you're closer to 12. Probably.
So are they trained in all those years to know the difference between emergency, life-threatening medical procedure to abortion? Or is he going to have to wait a few days to realize it's life-threatening?
If you know, Ms. Bush.
Mr. Chairman, if your question of me is how educated or how good are my physicians, I would say they're the best and that they know. I think what your question is there really that much confusion? I think you're questioning whether I think that there's actually confusion among the medical community. Is that fair?
Yeah, pretty much.
Okay. And I think the answer to that is there's so much gray in the legal framework. So are there questions in what is medically needed? Not at all. Are there questions what is legally allowed now and what will get them in trouble and what won't? Yeah, a lot.
Okay, Representative Ward.
Thank you, Mr. Chairman. Ms. Bush, are you suggesting that we need to kill more babies so that we can have more people to deliver babies in Wyoming?
Ms. Bush, that was your suggestion?
Mr. Chairman, of course, that's not my suggestion. But I do have an answer to your earlier question about midwives. And so I did find the Licensure Act, there is no requirement for supervision or even a relationship between a professional midwife and a healthcare provider. In fact, the law expressly prohibits the licensing board from requiring it. Welcome.
With that, follow up, go ahead.
Yes, my second question is, are you aware that abortion is almost never necessary to save the life of the mother?
If you want it, if not, I can go to Mr. Bowley.
Mr. Chairman, that's not what the medical science would indicate. Thanks.
Mr. Representative Trujillo, you're good? Your mic's still on. I just look for green lights,
Oh,
so.
yeah, I'm good.
Okay, Mr. Boley, thoughts from the hospital's perspective?
Well, Mr. Chairman, committee members, Eric Boley, the Wyoming Hospital Association, and we've covered a lot of ground today. I sent, it was late to the party, but Katie forwarded, this paper to all of you, I think yesterday, was it, Katie? Yeah. Anyway, if you take time to read it, I think it recaps a lot of what we covered. It's a pretty simple solution or a pretty simple problem with very complex solutions. And it really comes down to two things. It comes down to funding and it comes down to staff and personnel. And there are smaller parts that come with that, and that has to do with training, adequate staff. The decisions that have been made recently that have created the new deserts were strictly financial. And when we take a look at the birth rates in our state, it's decreasing significantly. You heard from Star Valley Health today that they deliver somewhere between 6 and 8 babies a month. So we're looking at maybe 80 deliveries. When I was in Kemmer, that was a good year for us. But consider that you're in a predominantly LDS community here that usually like to have lots of babies, and they're only delivering 80, right? And we were told they can't break even at 80. We've talked about the high cost, the fixed costs, and we can introduce midwifery, and we've opened that up and we're using that more. It doesn't change the narrative. It doesn't change the equation. The fixed costs still remain with those facilities, whether or not the baby's delivered at home or not. You still have to have trained staff 24/7 to take care of the what ifs. And that's an important thing to consider and to realize. We have to have anesthesia coverage. We have to have doctor coverage. We have to have at least one RN, maybe 2 RNs, and we need to have respiratory therapy, all sitting, waiting for the what ifs. That's expensive when you look at it 24/7. We talked about best practices. In Kemmer, I had 3 family practice doctors that all delivered babies, and they rotated the call and took care of call when they were out of town. It was hard to keep them trained. Even delivering 60, 70 babies a year, we were lucky. And I think this is one of the solutions if we talk about solutions. I had an agreement with one of the hospitals in Utah, St. Mark's, where I could send my physicians down and they could deliver 100 babies in a week. I could send my nurses down and they could shadow and spend time in the OB wards and keep their skill levels up. Not all of our facilities have that, but maybe that's something that we could build so that those physicians feel comfortable. Malpractice is a huge issue. And the question you ask, Chairman Zwanitzer, on our applications, each physician, we actually have to go through and talk about what they can and can't do, whether they can do C-sections, whether they can do VBACs, how many deliveries they do each year. And it factors into the rates that they pay, but they also take a look at the fact that they're up to date and that they're trained to take care of those patients and deliver babies. Question you asked, during coming to our state, and when they find out where we are right now, they're concerned and we're not able to recruit. They want to go other places because there is ambiguity and there is concern with existing law. I think there are things we can do with existing law to keep what the legislature wants in place, but to protect providers. Ms. Bush and I spend thousands of dollars on legal counsel. We have a webinar coming up at the end of this month to take a look at the current state of affairs for what it means to medical providers with the existing laws on the books and what happens if the trigger law takes effect. It is affecting our ability to recruit. And I'll use St. John's as a great example. think they have 3 OBs right now, maybe 4. 2 of those are getting ready to retire, maybe 3. So they've been trying to recruit so that they can continue to not be one of our deserts up here. They've had some great candidates come in, but then when they take a look at what could potentially happen to their licenses and what could happen to their livelihood, they've declined and decided to go elsewhere. We're hearing from the WWAMI students that there's concern. We can address those and still keep whatever it is that the legislature wants in place, but remove the ambiguity so that we can start recruiting and retaining physicians that want to deliver babies and want to protect the mother's lives and do the very best they can to take care of those patients. I won't spend a lot more time, but one thing that in this study, I think it's interesting. We talk about reimbursement. I think there are ways, if we want to make an investment, that we need to come up with a way to ensure that we're covering the fixed costs for the facilities and for those providers to keep those services in those communities. And we can attach whatever we want to that. I think that there is some responsibility with the insurers. I think there's some responsibility with Medicaid. $7,500 on average really isn't close to covering the costs of delivery. There's a whole different, I am aware of the adoption laws that you talked about, Representative Hornick, and there's a whole different matter that goes into that $40,000. And we've gone through it with our families. Part of it does go towards the medical care and towards that part of it goes to the adoption agency. There's expenses that are incurred, but it does cover the expense of delivering that baby in that facility. So I think we can work together, but these are the barriers that we're facing, and they're because of the traveling staff that they took in during the pandemic, where they spent most of their reserves. They had to take a look at their different cost centers, and they had to cut those that were losing them money. And I think that's really what's happening in a lot of our small communities. So I could go on forever, but I'll answer any questions.
Representative Hornick.
Thank you, Mr. Chairman. So you mentioned staff that needs to be basically on the ready, just in case, even if there's a home birth or something, which that makes sense. But you know, I asked the question earlier, isn't it also true that some of that nursing staff and other staff within the hospital, that staff is not I don't know what the word is, confined to just the birthing area? It would be that the cost of that staff, that's cost of that nurse, can be spread out through all of the departments. So it's not necessarily that that we need to figure out a way to break even with our birthing centers in hospitals, but generally hospitals, you know, should be breaking even across the board. This is one piece. It might lose money on this end, but money's made up in other areas.
Mr. Chairman, Representative Hornick, I think in theory that makes sense, but the reality is most of our hospitals are losing money in just about every one of their departments. Yes, there is not always dedicated staff. My nurses were cross-trained so they could work in OB, they could work in surgery, they could work on the acute care floor. However, if that pregnant mother comes in and is in distress and the baby needs to be taken C-section, or the baby's breech, or whatever it might be in the home delivery, that person's got to be pulled off the floor and has to be dedicated to that. And then we have to call in additional staff to take care of the rest of the facility. So to a degree, yes, but the reality is there are only a couple of cost centers or a couple of service lines in hospitals that actually help us make money, and the rest of them are loss leaders.
Okay, other questions for the hospitals? Seeing none right now. Mr. Bully, thanks.
Thank you.
Anyone else here to testify on maternity deserts? Let me make sure there's no one on Zoom real quick. Hey, she is. Give me just a second. We'll bring her in. Go ahead, Rich.
Mr. Chairman, are you able to hear me?
Yep.
Right. Mr. Chairman, as a practicing family medicine obstetrician, obviously I'm concerned by the increasing lack of obstetrical services within our rural Wyoming communities. I grew up outside of a small community by the name of Bloomfield, Nebraska, in northeast Nebraska, and Dr. DJ Nagengast was our local family physician. He delivered me along with all of my siblings, so I was quite accustomed to OB care in a small town setting. Throughout my time practicing in several communities across rural Nebraska and in rural South Dakota, I saw a similar model of healthcare where obstetrical services were offered to small communities. I practiced in Kemmer during the time of their OB program closure, and I take a major personal responsibility for this. And I'm passionate about not allowing this to happen in other rural communities. It would be great if we could not only get Rollins and Kemmer to reopen their OB programs, but also grow obstetrical places in such places as Newcastle and Lusk, and maybe the new hospital under construction even in Pinedale. We have to really ask ourselves, why would a young couple looking to start a family move to these areas when the community does not even have the basic services to care for their family? So what's the solution to the problem of decreasing OB services in our small communities? I believe, like Nebraska and South Dakota, Wyoming needs to encourage more family physicians to provide obstetrical services in rural areas. Not only can a well-trained family physician provide OB services, but can see clinic patients, nursing home patients, hospital inpatients, and cover the ER. We have 2 family medicine residencies in the state of Wyoming that should be able to produce enough well-trained family docs to meet the needs of Wyoming. And in the same way, Wyoming needs to focus on training more generalist nurses who are cross-trained to work in different areas of the hospital. This would allow hospital administrators to decrease the significant cost of locums coverage for both nurses and physicians. As legislators, I encourage you to sponsor training programs not only for our future rural healthcare professionals, but also for the current staff we have placed in our small communities. I can't help but think that some of our current nurses, physicians, mid-levels, etc., wouldn't jump at the opportunity to broaden their scope of practice by participating in a structured apprenticeship program. A prime example of this is what Mr. Boley just spoke to. During my time in Kemmer, Dr. Krell also mentioned that they had a similar program they had set up somewhere, I believe, in Salt Lake, that was responsible for C-section recurrency for their family physicians. The family physicians would travel to Salt Lake for a week or so to scrub in on 5 to 10 C-sections during that week. Unfortunately, COVID occurred and the program unraveled after that. But these are the sort of programs that could ultimately benefit our small towns. As you can see, I don't have any fancy charts or statistics to back up my testimony today. Just 25, almost 26 years of experience since graduating in '98. Certainly, you'll find many differing opinions regarding this issue. Please know this is just the opinion of one little tiny country doctor who believes, as my father always did and always told me, the future lies with the young. If we subscribe to this self-evident truth, we have an obligation to improve the care of our mothers and children across our beautiful state. It's been a long day for all of you, and I thank you all for your attention. I thank you for not nodding off during my testimony, and thanks for serving our state.
Question for Mr. Haggie, Dr. Haggie. I'm not seeing any, but certainly thank you for joining us remotely. And I am optimistic we'll be pushing several of those ideas you just mentioned forward here for our next meeting. Other members of the public? Right. Seeing none, committee, this would be the time to start generating some ideas for our next couple meetings on avenues you'd like to pursue. Not that we have to commit, but just, get some statutory, codified or non-codified law together on some options. Representative Ward.
Thank you, Mr. Chairman. As you probably expected, I'm interested in solutions that give more freedom, not more government. So how can we either do tort reform so that we reduce liability on certified professional midwives and certified nurse midwives? How can we make it easier, even though they're not required to partner with an OB? They practically have to partner if something goes wrong. How can we make that happen? I'll repeat my previous idea that if you're an OB who accepts any kind of government funding, then maybe you should partner with the CPM and or a CNM.
So as an idea, you would, I'm looking for more of a motion.
I move that we look at tort reform and reducing liability for caregivers practicing in the birth field, CNM, CPMs, and OBs.
Okay. LSO, is that enough to start a generic kind of draft in those areas, and we could work on in our next meeting, or some questions for us on how to tailor that, Anna?
Mr. Chairman, I think we have some older legislation that's already looked at tort reform in this area that we could probably look at. I think we probably have enough to draft something, probably with some staff comments and whatnot, and the committee could fill in the blanks. So.
There's seconded by Clouston. Any discussion on that committee? I guess we can do motions. All those in favor say aye. Oh, there's discussion. Senator Dockstader, go ahead.
And somebody with some institutional history for that special summer session that we had. All the legislature came back just to deal with tort reform and it failed. What was the big problem there? That was an ugly session and it didn't work. A lot of money spent from the legal side. None of that came together. Why do we think it'll come together this time?
It was a long special session for those people who were there that didn't produce much. I agree. During an election year.
I think
Senator Barlow, did you have some discussions on that? I think that
Thank you,
special
Mr.
session
Chairman.
happened in 2004. I just know it helped me campaign because my opponent was in the Capitol for a month. But I think maybe Senator Barlow is waiting for the next motion.
Mr. Chairman, there seems to be a tremendous delay.
Go ahead, Senator Barlow. There's a 20-second time lapse, and
okay,
the floor is yours when you hear this.
Thank you, Mr. Chairman. So I appreciate that we're trying to get at some answers. What I wonder is if there's some like policy papers or position. What have other states been doing in the last 5 or 10 years that have these similar challenges? Rural states. I know we like to figure out what's right for Wyoming, but tort reform is an uphill thing. I remember the 90s when we took it up and I also recall much of the discussion. I wasn't in the legislature in the 2000s, but I also remember much of that discussion too. So are there other things? I appreciate what Representative Ward is talking about when it comes to the, how do we have allied, how do we build relationships with some of these between practitioners? And I think to do that, maybe that some of the partnership things that the doctors, the obstetrician talked about, some of these training opportunities might actually help do some of that. So maybe there's some other things we can do. I'm not saying this motion is a terrible motion. I'm not going to support it because I think tort reform is a way uphill battle or uphill climb. But I think some of the other things we should probably take a look at. Thank you.
And we certainly don't have to have a bill drafted because we do have 2 more meetings. And so we could make it a request for more information. Would that be better as an award? Go ahead.
Thank you, Mr. Chairman. So I think last time tort reform was looked at, it was the whole universe of tort reform, if I'm not mistaken, not just OB and certified nurse midwives and certified professional midwives. I'm narrowing it to the focus of those practitioners. So not the whole universe, just that. And yes, in answer to your question, we can gather more information before we suggest a bill draft.
Okay. And perhaps we should do that. I think tort reform is it's constitutional, correct? And it would take a constitutional amendment for when we say tort reform of upping limits and caps. But if there is a way to, I hate to use the word subsidize, but incentivize or financially offset some of the costs in this area, we can do that as a legislature without a constitutional amendment. I like when people in the audience are nodding and agreeing with me. So LSO, is that enough to kind of research what other states have done? See if there are ways, I think as a medical society said, to offset costs for any of the practice areas that work in this field and help cover some of those costs, or the training or their malpractice insurance. We certainly put that as a research topic for us to look at. And I know Senator Barlow has another suggestion. Go ahead, Senator Barlow.
Thank you, Mr. Chairman. I think to Representative Ward's point, I think the language, there's still statute that it carries over from that 2004-5 discussion, where there is a risk pool, a high insurance risk type pool still in statute, where we could use that to direct it toward a particular type of service if we wanted to. So I think that some of that's still there. It's just not being utilized, if you will, Mr. Chairman.
Okay. Other incentive ideas, committee. I know we certainly just heard from the good doctor about training opportunities, or if we could get some research on what that would look like for a more advanced cross training, additional courses that they could get a reduction, or if they did take on that extra specialty to cover those costs. And I'm not saying it correctly as I heard, but I believe you took amazing minutes and notes, and I'm optimistic from that testimony from both the medical society and the good doctor that you can proceed down some research in that area. That'd be correct, Anna?
Mr. Chairman, yes, that's correct.
Okay. There's 2 or 3 areas. Committee, other thoughts? I mean, certainly we have not looked in 20 years about upping the Medicaid rate across the board. I mean, I have difficulty saying we should do it in this area, especially knowing that every other specialty is going to come in and say, oh, wait a minute, not fair, because there's a lot of other struggling areas in the state besides just maternity. But we certainly could look at it. It's amazingly expensive for like a 1% increase. I don't remember, it's 15 or 18 million general funds. All the Department of Health left already. But we could look at that as a committee if you'd want. Maybe I could just ask for some research also on Medicaid rate, what it would cost to reimburse. And if there is some type of specialty program, quote unquote, an upper payment limit in this area somewhere, what that might look like. Other Representative Ward.
Thank you, Mr. Chairman. Didn't we have to vote on my motion first?
Oh, well,
It is a motion. Withdraw.
I'm sorry. I thought when you said, yeah, we could do the research, you didn't need the.
Okay.
Is that okay?
That's
We're totally pursuing it.
okay. I just wanted to make sure. I wasn't sure procedural.
Yeah.
Officially withdraw.
Officially withdraw.
Okay.
That'd be fine.
I withdraw.
And then, and the second, okay. And that way we can just do a lot more research, maybe spend some more quality time on the subject, get some bills drafted for our August meeting in this area. So if there's no bill draft motions, just asking LSO to do some research and your committee chairman to put some ideas on the agenda for Pinedale. Representative Klaus.
Thank you. You know, Dr. Hagee mentioned we should do what South Dakota and Nebraska do, which helps.
Representative Ward.
Thank you, Mr. Chairman. I'm sorry to be confused. I think you said we have a meeting in August, but I thought it was in June.
We have 2 meetings. Next one is in June in Pinedale. We can have the data and present it and ask for bill drafts at that meeting for ultimately our August meeting, which would be our 3rd meeting, the end of August. Is what I'm hoping. So we don't actually have to ask for any bill drafts right now if we need a lot more research and study. Representative Yin.
Mr. Chairman, I would be interested if we can get some information from the community colleges on what it would look like to stand up a midwifery program, especially in places that we know we have deserts.
Clayton, easy enough? Okay. Representative Trujillo.
I don't know who would be able to get this information, but in the discussion today, it sounded like the OB doctors have problems working with midwives and family doctors in sharing their spaces. I'd like to know more on that.
And we do also have the OB subcommittee in the executive branch as well. And so Ms. Davis, I am sure, is looking forward to helping us on some of those topics in coordination with LSO. If you have some previous information you could share with LSO and have some conversation, make the work easier on everyone to get some of these fields of research completed. That seems like 4 or 5 pretty strong topics of places we could go. Anyone else want to ask for a study? Representative Senator Bouchard.
Thank you, Mr. Chairman. So where I'm having a problem is for the last decade, all I kept hearing is doctors are leaving. And, you know, we just recently heard it was because we passed a law here. But if we look at January 18, 2022, AMA released a survey saying 1 in 5 doctors plan to exit in 2 years. Goes on to say that it's our study demonstrates that the U.S. healthcare workforce is in peril. Even if 1/3 to 1/2 of the nurses and physicians carry out their express intentions to cut back or leave, we won't have enough staff to meet the needs of the patients. So I'm just kind of wondering here if we're trying to band-aid something that we're not going to be able to do. So I want real numbers here on how many doctors plan to leave. There's got to be more than just this survey. But I've heard it from doctors. I've heard it that they can't make money on paid healthcare. So I mean, I want to see if we're maybe beating around the wrong bush, if that makes sense. I mean, I don't know if that's the right study, maybe to look at how many doctors plan on leaving. Maybe this is something we can't fix, and we're just spending time and money on things that's not going to help.
So the Department of Health left before the massive rainstorm outside, but perhaps we could take a note and maybe ask Medicaid how many have disenrolled, how many providers in the last, year, 5 years have decided they will no longer, take Medicaid, and see if that trend is increasing or decreasing. And second, I don't know, Ms. Bush, if there's a poll of your membership asking what their kind of future plans or thoughts, or if there is something to engage the community on, or just how many are retiring. I think it'd be great to know kind of where we are demographically on our physicians retiring and or wanting to leave Wyoming. And we're doing all that in education with teachers right now. So if there is something your organization can do to do some polling before either a Pinedale or a Cheyenne meeting, I think we'd appreciate. Yeah, the question is, can we solve the problem, right? In the least populated state, we can keep trying. Other thoughts in this area? Not seeing any. So that should be enough to keep us busy for what, 6 weeks until Pinedale? We can certainly talk about childcare. Your mic's on again, Senator. I know Miss O'Connor's here from DFS. Question is committee. We can certainly come in at 8 o'clock tomorrow. I understand DFS can come present in the morning as well as everybody else will still be here. Or we can talk about childcare now or come in at 8 a.m. Which would you prefer? 8? That work for now?
Can we just get it done so we can get out of here a decent time tomorrow?
Certainly depends on how many questions come up and how much we want to talk. So do you want to do childcare for the next half? Well, for a while. And I mean, it's another area we struggle with, what we can and can't do. Miss O'Connor, how long do you think your presentation is?
Tomorrow.
But maybe 10 or 15 minutes?
Do it tonight.
Okay, let's try to, I mean, it's raining pretty bad out. Might as well stick through it for a bit. So come on down. As part of the same topic, not only, okay, floor is yours.
All right, thank you, Mr. Chairman. My name is Roxanne O'Connor. I'm the Support Services Senior Administrator for Department of Family Services. Director Schmidt wishes that she could be here. Unfortunately, she had a family emergency and wasn't able to join, but I'm guessing she's one of the 4 directors that are online with us. I do have a policy brief that we created for you. There is also a slide deck that will allow us to speak to the highlights of that policy brief. You will see page references on the slide deck that will point you to the areas in the policy brief that I'm speaking to. As a quick introduction to Department of Family Services, we have 3 agency core values. Those values are safe at home, opportunities for success, and supporting the people who support the families. We believe that families do best when they are safe at home. And so at DFS, we try very hard to make sure that there are concrete supports available to help families, whatever their situation may be, so that they can stay safe at home and that children can thrive in those environments and they can have that comfort and that stability at home. That all lends itself to a framework that is called Why Home Matters. And Why Home Matters melds these 3 core values together to provide community supports and engagement from communities to be able to really target and provide specific interventions to families so that they can, again, be at home, and DFS has less involvement and less intervention because of the community-specific supports that we are able to provide. How does that relate to childcare, you might be asking? There is a growing body of evidence that concrete supports such as childcare reduce child abuse and neglect for families. As you can see, childcare assistance, which is a program that I will be speaking about in a little bit here, is associated with a 16% decrease in the odds of neglect and 14% decrease in the odds of physical abuse of children. Additionally, we found that the ability to locate childcare is a strong predictor of maternal health. Can go to work or be provided with education so that they then can support their families, again, without a whole lot of DFS intervention. Now, speaking directly to child care deserts, similar to healthcare deserts, DFS participated in a bipartisan policy center study that showed that Wyoming does have a 27.6% childcare gap. Now, the Bipartisan Policy Center defines a childcare gap as the difference between the potential need for childcare as compared to the supply of childcare for children under the age of 6. A potential need is defined as any child under the age with any, a potential need is defined as all children under 6 with parents who are in the workforce. So though we have seen a decrease in our childcare gap in Wyoming of about 8% since 2020, and our childcare gap is lower than the national average, there are still communities that struggle to have access to childcare. Families struggle to have access to childcare. And then that becomes an economic issue. That becomes, that impairs families' ability to work. And then we have other supports that need to come into play because of a lack of childcare. And just a little bit of background about the child care system within Wyoming. It is a pretty fragmented system. Child care or early care and education spans about 4 different departments. The first department is Department of Workforce Services, where there is a Y Quality Counts program. That program is specific to workforce development. So it provides scholarships to child care providers for them to continue their professional development, to earn their credentials, and to really professionalize the roles that they play as child care providers. Then we have the Department of Education, who has the temporary assistance for needy families preschools, the Head Start Collaborative, and Title I preschools. And then Department of Health, they have the programs that are called Individuals with Disabilities, the IDEA, Part B and Part C. Those are your child development centers across the state. And then we have Department of Family Services. As I mentioned, Department of Workforce Services plays a large role from a financial perspective in early care and education. We are the recipients of the Child Care Development Block Grant, which is a block grant that we receive to promote childcare access, safety, and quality in Wyoming and across the nation. It is a federal block grant. So of our childcare budget, the total budget is $21.2 million. About 73% of that funding is federal funding directly through the Child Care Development Block Grant. And the remainder of that funding is match and maintenance of effort through state general fund. Within the block grant requirements for that funding, we have certain set-asides. So the biggest set-aside is for child care assistance. So for the assistance programs for low-income families to be able to have access to child care. As part of the block grant, there's a requirement that 70% of that funding goes directly to families through the child care assistance programs. And then we have additional set-asides. We have a 9% set aside for quality activity, which includes professional development and training for providers. And it also includes ensuring that providers have access to early care and education learning standards, so child development standards, and it covers our licensing costs as well. And then we have a 3% set aside that's spent on infant and toddler care, such as safe sleep practices and training that's specific to caring for infants. We also have administrative costs that are capped at 5%. So you can see there that very quickly we have a lot of our funding that is prescribed to certain areas, and that leaves very little state general funds to do anything really outside of those set-asides. So like I mentioned, Department of Family Services through the block grant manages the Child Care Assistance Program. This is a means-based program that provides financial assistance for low-income families who are working, who are in training programs, who are participating in an educational program, who are looking for jobs, or who are shift workers and need respite when they are off shift and need some sleep time and need a place for their children to go safe and be safe. Program and 2,800 children that qualified for financial assistance. And about 62% of our licensed providers accept child care assistance. So not only do you have to be an income eligible family, you also have to find a provider who is willing to take child care assistance. And so that then narrows the pool for those families to be able to access child care. And then our other large program within our early care and education is child care licensing. And child care licensing, we have about 13 licensors all across the state who go in, they work with providers, they conduct 3 visits a year. One of those is unannounced, and they ensure that basic health and safety regulations are met in regards to safety of children. And so this is a requirement of the block grant to have licensing in place. There are certain rules and regulations that need to be met as a requirement of the block grant. And our staff work very hard to ensure that there is a lot of technical assistance provided to childcare providers to ensure that they are meeting the rules, to ensure that at the end of the day, children are remaining safe and healthy in their home away from home, if you will. Figure 1 is a way for us to illustrate which childcare programs in Wyoming we regulate and which ones we do not. And so on the left side, you'll see a column that has 3 red squares. And those are the providers who are by statute licensed within Wyoming. Those are childcare centers. So those are your large childcare programs, 16 or more children. Family childcare centers, which are in homes, but they're a little bit larger. They can take up to 15 children as long as they have staff, as long as they are up to fire code and fire standards. There's certainly some requirements that they have to be able to have that many children in their home. But they are our biggest home center. And then we have family childcare homes, which are our smallest licensed programs, and they can have up to 10 children in their home. And then the middle column is a column that is a little bit of a gray area, if you will. We have before and after school programs and family friend or neighbors who wouldn't necessarily be licensed, necessarily statutorily required to be licensed, but because they are accepting federal assistance or federal funds, they need to follow certain purchase of service rules. And so that's the second column that you see. And then we have providers who are unregulated or license exempt per statute 144102. And you can see, as you'll see in the statute, it's a pretty lengthy list. It's a pretty detailed list. We've added a couple over the past couple of years. But these are your very small in-home programs where you're serving just one family or 2 unrelated children. Your before and after school programs who aren't receiving childcare assistance, and summer camps, just, a myriad of different programs that aren't considered for licensure per our statute. On the next slide, you'll see where we have had a steady decline in the number of childcare providers across the state. You'll see that in 2010, we had 855 providers, and now we are down to 552 licensed providers. One thing to note in this chart is you will see that our licensed capacity, which is the number of children that can be in attendance at at centers across the state, that's actually gone up over the years. And so what that tells us is that we've seen a decrease in the number of small providers and the number of home providers, if you will, but we have seen an increase in the number of larger centers who can take more children. Something to be very mindful of with capacity is that just because you have a certain license capacity, you may not have staff to be able to serve that many children. And that is the biggest thing that we hear across providers is a workforce issue, right? They might be licensed to have 60 children, right? A very viable business that's going to support a lot of children and a lot of families and communities. But if they can only find 3 or 4 staff, then they're not able to have that number of children. And so really, we're seeing this problem as a workforce problem. We're seeing a lot of home providers that retire, and then there's just not a pipeline to backfill from a home provider perspective. And we've put in a number of different initiatives to try to address the problem. The first is taking a deep dive into our payment practices and our rates. We did increase our rates through COVID. We increased our rates through ARPA stabilization dollars. We then took a deep dive into our block grant to ensure that we could sustain that rate increase. And through really diving into the numbers, we were able to do that. This is the first increase that we have had in the Child Care Assistance Program since 2012. And I should say that's the first change that we've had since 2012. The change in 2012 was a decrease. And so though it may seem small, even increasing those rates is a big step for Wyoming. We've also adjusted our payment practices to mirror more closely to private pay practices so that childcare providers who do accept childcare assistance ensure that they have a continued revenue stream and that they know what they're going to be receiving and that they can serve all families then because they'll be able to staff appropriately because they know what DFS is going to pay and when we're going to pay. You may have noticed I don't have nearly the quantitative data that you received from the Department of Health. That's because I will say our IT systems are not nearly as sophisticated. We have embarked on a really amazing system project. It's called the Child Care Exchange or eCares, where we will be connecting families and all families across Wyoming, not just families on child care assistance, but all families. And we'll be connecting them directly to providers. Providers can come on this site and they can advertise their business and we can make a one-on-one connection with providers and families so that they are able to quickly identify where care is available, get themselves scheduled for a tour or whatever the next step might be, and then be able to really make that onboarding process a quick and easy one. This is also where we're going to modernize our payment practices from a provider perspective. It's a little humbling to say that we still currently use carbon copies for provider invoicing. And so we've noticed that there needs to be a change. And so we are, like I said, working diligently on the system to be able to take care of children. This is also where we're going to have our workforce development module, where all providers are going to be able to come. Their training is going to be in one place. their credentialing for background checks for central registry, all of those requirements will be in one place, again, looking at trying to reduce the administrative burden of operating a child care program. I will say that we have looked at our processes. For one example, I mentioned central registry, which is our abuse of individuals who have been substantiated upon for abuse and neglect. And that's one of the checks that we do for childcare providers, is to ensure that they're not on the central registry. We have, through modern IT modernization, we've reduced the turnaround time for central registry checks from 12 business days to about same day turnaround time. So it's looking at all of the different facets of becoming a licensed childcare staff person and ensuring everything that we can to make sure that that is a really easy, modernized process. We also received a consulting grant from our state capacity building center, where we are building provider toolkits that are specific to communities, because there are different regulations for zoning, for fire standards, for health and safety, from a sanitation perspective. We're building these toolkits so that providers or anybody who's interested in becoming a provider can use this. They can go to a family resource center, which I'll touch on in a minute, and they can more easily navigate the requirements that it takes to become a licensed provider. And then we are also working closely with other state agencies through our preschool development grant. So those agencies that I listed on the previous slide, we are working to get data together from all of those different agencies to bring it into one system so that we can look at the whole early care and education spectrum, and we can look at outcomes for early care and education from an educational standpoint, from a service standpoint, from an access standpoint. So we're excited to be able to bring that together and really start to drill down on where those supports are or where they are not. Additionally, we have contracted with a vendor called ICF. I looked up their website. I do not know what ICF stands for, and it doesn't say it on there. We're ensuring that they're not too prescriptive, that they are easily adhered to, that they're easily understood. So just providing a lot of clarity and some streamlining around our rules there. We do keep provider voice in mind as we go through these rules reviews. We've heard from providers that regulations don't seem to be overly burdensome in Wyoming, but that doesn't mean that there's not always an opportunity to review, to modernize, to really ensure that what is in there is necessary and that it really does align with health and safety of children at the end of the day. Last slide. Also, like I mentioned, we have partnered with the Wyoming Children's Trust Fund to develop family resource centers. And these are going to be resource centers across the state. The best way that I can describe them is really navigational resources for specific communities. These family resource centers are going to be equipped with the provider toolkits that we're creating to, again, have a place where potential providers, families can go to understand what it takes to become licensed, what it means to be licensed from a consumer education perspective, and where there might be slot availability. So it's connecting families and providers together at a community level. We are also partnering, and this is very exciting, with the Wyoming Business Council to improve access to childcare, because it's recognized that childcare is a cornerstone to economic development and growth, especially for young families. So through that project, we have partnered with the Wyoming Business Council and also the Harvard Growth Lab, which we may or may not have some individuals on from there as well. Okay, we'll see. But Director Durrell would like to speak to some of the policy packages that the Harvard Growth Lab has looked into in regards to childcare in Wyoming. These researchers came out to Sweetwater County, to Sublette County. They met with providers. They wanted to hear about kind of all of the different aspects of what it meant to be a provider in Wyoming, what drew individuals to the childcare sector, what didn't, what caused burnout. And so they took a deep dive into the research, met with providers.
Yes.
I'm experiencing quite a bit of delay. I'm going to assume that you have are asking if I have any comments to add. Is that correct? Okay, I can see the video that Ms. O'Connor is giving me the thumbs up. Mr. Chairman and committee members, thank you for allowing us to chat about this evening. Thanks for the time, because I think one of the things that we need to do is kind of just take a quick step back. And as we look at the economy of Wyoming, we know that we're working hard to develop resilient communities. And one of the keys to that resilient communities is to have a thriving business community. To have that, you have to have workforce. And we know that the workforce that we have in Wyoming has actually been shrinking over the course of the last few years, and quite a bit of time, especially in comparison to our neighboring states. And we estimate that there are likely 10,000 individuals across the state that are out of the workforce due to childcare issues. And what that means is that we are not as competitive as some of our other states when it comes to helping businesses grow that are already here, which is a big deal for us, or attracting new businesses that are going to help make our economy more resilient. And so one of the things that we have been looking at is how do we address this issue? And what we're finding is that a lot of the programs that have been put in place are demand side. They address the demand for and help for people to be able to pay for childcare. Well, what we're seeing is that there's an inflexibility, or there is really kind of lack of elasticity on the supply side. So the demand is growing, but the supply is not growing with it, which indicates that there are some other issues at play. And so one of the things that we're looking at is how do we address those particular point issues and make sure that we're doing it with laser-like focus, not necessarily broad, sweeping, big programs that are silver bullets intended to solve everything, but rather what is really going on and why is supply not matching demand? Now, we have done some of that right now, as Ms. O'Connor mentioned. There have been a number of people who have worked on this issue, and they've just taken a look at a high-level data. But they've also gone on the ground in the locales that she mentioned in the southwest corner of the state to understand more about what that problem is. We actually think that it's a business problem that could be solved with business programs, and the private businesses will ultimately solve this with maybe some help from us as we further understand it. So if we could say anything to the committee and the folks here is that one, we believe that business can solve this, and it will be a private solution in a lot of cases. I think with some help from us and of course from DFS, who's been working on this problem for quite a while and who knows it better than anyone. And I think the other important part is that there may be some policy adjustments. There may be some programs that can help out with that. But ultimately, we want to make sure that we're looking at it from more of a surgical perspective, not a big program that runs and maybe doesn't solve the problem. So for us, we think it needs a little bit more work on understanding the problem, a little bit more understanding of the individual cases that we're working on. And then we can develop some programs or some policy changes that will affect those. We do have some areas that we're looking at now, as Ms. O'Connor mentioned, but they're going to require a little bit more depth before we can make any policy recommendation. I think it's also important to note, and this is, while it's semi-philosophical, I do think it's really important for us to recognize the willingness of Department of Family Services to sort of see this and see the work with the Business Council as, you know, breaking down silos and working on a common problem with two different lenses. We obviously look at it from a workforce perspective and availability of workforce. They're coming at it from a slightly different perspective, but together what we're able to do, I think, is come up with solutions that actually make sense, and again, make that business and government work in the right ratios there. And I'm happy to stand for any questions, and I just appreciate the work that Ms. O'Connor has brought forth and the work that she's done with our team.
Representative Yin.
Mr. Chairman, thank you, Mr. Durrell. Do you think it would be worthwhile to set up some sort of targeted task force with the business community involved to really hammer out what those problems are so we can identify solutions? I'd like to do something quicker than frankly than a bill for a task force. We could probably just petition management council to initiate one and get something going, just so we can start generating solutions sooner rather than later, and maybe bring something back to the committee by August.
Thoughts, Mr. CEO?
Thank you, Mr. Chairman and Representative Yin. You know, that could work, and I'll leave it to, I'll also leave this to my colleague, Ms. O'Connor, to talk about how we can do that, because there might be ways, and we're working on that now. We might be able to bring more information to the table, sans a task force. But again, we'll take the help that we can get, and so I think if that is what you're offering, we're all for it. I think more hands would be helpful here in this situation.
Okay, other questions for CEO Durrell? Go ahead, Representative Penn.
Thank you, Mr. Chairman. I mostly just want to follow up on the previous question. What I was hearing is they said that it's believed that businesses can solve this problem and have a private solution, and that we still need more input to make some decisions. And so I think it would be hasty to move a lot quicker without really knowing the issue, especially if this is not something that government should be getting our hands into at this time.
Okay, any other questions for the CEO while I have him? Not seeing any. Thank you for being with us tonight, Mr. Durrell, and thanks for waiting. Certainly appreciate your time, and hopefully look forward to seeing you at one of our future meetings as we keep talking about this topic. Other questions from Ms. O'Connor while I have her up? See, yes, Representative Penn.
Thank you. So this is not necessarily on the info you gave us today, but on one of the reports that we got quite a while back, several months, I believe, a report on the grants for the child care trainings is, you'll have to tell me, I can't remember the name of it. I have it under here, but I was just reviewing that, and one of the notes was they had printed the comments from people who had attended the grant trainings or taken the grant to attend trainings that were put on by the state. One of the comments said, great training, but they need to lay off the left-wing propaganda. What kind of things are happening at these trainings?
Ms. O'Connor, if you know.
Thank you, Mr. Chairman. Representative Penn, are you referring to the why quality counts training? I'm not sure I know specifically what training.
Well, Representative Penn, oh, we got it. Go ahead.
Yep. So this report here, annual report to Joint Education Interim Committee, Joint Labor Health, Quality Child Care. And they were talking about the grants for professional development, technical assistance, business management services. So you can look at this if you want, but.
Director Gagan and Administrator Simone, we'll bring them on in here. While they're coming in as well. I do see Director Schmidt, Roxanne's done amazing, but if you did have anything else to add after workforce, you're welcome to. Hi, Miss Simone. I don't know if you heard the question from Representative Penn on Director Gagan. Let me have Representative Penn repeat the question for both of you on the Y Quality Counts program and see if you can throw some answers at us. Go ahead, Representative Penn.
Thank you, Mr. Chairman. So I'm looking at the report that we were provided as a committee, I believe in September of 2023. And yes, it is from the Department of Workforce Services, so I apologize for my earlier misstep. But part of this report that we got offered some comments of grant recipients in the survey that they were given afterwards. And I'll just read the quote. It says, absolutely loved most of the training, just needed to lay off the left-wing propaganda. And so I just raised my eyebrow a little bit to say what exactly is being pushed, directed, taught at these trainings.
Welcome. I guess we'll start with Director Gagan. Welcome on your new role and promotion, and we'll give you the floor first to respond.
Okay. Thank you. And hello, committee. My name is Liz Gagan, and I am the Director of the Department of Workforce Services. And Mr. Chairman, Representative Penn, in response to your question, the Department of Workforce Services does not, we provide grants for childcare providers who find the training on their own. So any of the feedback that we receive is not a training that we have sent a childcare provider or facility to. It is training that they have chosen.
But if we might want a list of who's providing those trainings, if that's easy to do, Director Gagan, to maybe send the committee a list of who those providers are. While I have you both from Workforce Services, anything else you'd like to discuss when it comes to child care and what the department's doing?
Chairman Zwanitzer, we are happy to answer any questions. I know that Y Quality Counts took up probably about a page in the memo that LSO wrote, and we are just happy to answer any questions that you may have.
Okay. They're wearing down here, so I'm not sure we have any questions, but we do appreciate you staying until 6:30 with us. And we'll see if this carries on to tomorrow or we get it done tonight. We'll find out. But seeing no further, you're off the hook for now. Anything more from Ms. O'Connor? Anything from the governor's office or the Wyoming Women's Foundation on these issues? If not, LSO does have a memo. Mr. Caldwell did some research in this area. And we'd invite him up for a couple of minutes. And while he's coming up, I guess I've been allowed to inform you when we were at the hospital over the lunch hour and we were told that we shouldn't be hanging out in the labor and delivery area because two women were delivering. One of them happened to be Representative Simpson's newest grandchild. So he was born while we were actually at lunch today there in Star Valley Medical Center. Representative Simpson was the legislator you saw earlier today. So that was his granddaughter born. Exciting stuff. With that, welcome, Micah.
Thank you.
Actually, well, you're with Clayton. He's going to provide some stuff in conjunction.
No, we're not.
You're not
just hanging out at the same table,
well,
but don't know what Clayton's going to be talking about. But I actually, if it's possible, I was going to address the committee about we have a So the Wyoming Women's Foundation is under the umbrella of the Wyoming Community Foundation, and we have a Du Bois local board. And that local board has been working on childcare issues. And we have two, and really it's more from a personal parent perspective. And they are on the Zoom call. They were not able to, they couldn't find the registration to testify, but Sarah Domack and Casey Sedlak, if you are, they will be much more interesting to listen to than to me. And if you are willing to hear from them, great. If not, I am happy to share their information on their behalf.
Well, Miss Sedlak's been with us all day, but I finally got her to join the room. So, yep, you can go back and sit down. And Casey, the floor is yours as soon as you hear this.
Thank you. Can you hear me? It's hard to tell, but I think I'll just speak. So my name is Casey Sedlak. I live in Crowheart, Wyoming, and I was formerly on the board of the Wyoming Community Fund for Du Bois and Crowheart. I no longer serve, but I'm still very integrated in the Child Care Coalition, as we started calling ourselves, of the Upper Wind. And I'm also a parent of 3 children, ages 3, 5, and 6, all born in Fremont County. And let me tell you, maternal health care, what an important topic here for Fremont County. But today, I really do want to speak to the difficulty that we as a community in the Upper Wind are facing to host and sustain a childcare outlet for our children and parents, particularly under the ages of 5. At the end of 2019, I had my 2 children at the time in a daycare that allowed me to start my business in consulting. And that very shortly became the only daycare for children in the Upper Wind country that served children from the infancy stage to age 3. And it very recently and very suddenly closed, leaving a significant portion of our parent population in jeopardy when it came to childcare. It left a significant hole in the dynamic of our community, as many of those parents with children in the daycare are also educators or work in the Du Bois school, thereby creating a crisis of who is able to attend. And this goes into other issues of shortage of staff or substitutes for the school and for the daycare. And this is why one of the reasons why the daycare closed was, I think it was really spurred along by burnout and an inability to just be present with, all of the time without extra support when there was illness or emergencies, et cetera. So myself and 3 other women, one of them, Sarah, who's here with us tonight, who serve on the local board or who have served on the local board for the Wyoming Community Fund, started this initiative actually several years ago to focus on the critical need for sustainable childcare in our community. And it very, very rapidly, like almost overnight, turned into a triage situation after the closure of the daycare, or really like the week before. We've explored many, many options for basically providing triage childcare to the people who are the most significantly affected by this closure, namely our educators and people who make the school run in Du Bois. Those potential options we've explored have been hiring volunteers or looking to volunteers to help. How do we utilize our local churches? We've talked about a parent co-op, doing a nanny share, but all of these have either been highly regulated, such as the nanny share and access to volunteers, making having any access to regular childcare highly preventative, or have been impossible options for us to pursue because of the nature of our parents' work. And that was what prevented the co-op from being an option at all. So I only had the luxury, speaking from a personal perspective, I only had the luxury of accessing childcare for a total of 16 months of my children's infancy and toddler years. And 3 of those months were at the daycare where that recently closed. And one of those, I was lucky enough to be able to hire a very flexible and just absolutely gracious nanny to live with me and my family for a year. And I can without a doubt say that that woman saved my marriage. So childcare is important. It is important. It is important. And it allowed me to blossom into becoming a businesswoman, and not only for my consulting business, but also for me and my husband to get our ranch our family run ranch off the ground. And what I would really like to press today is that I can't remember who said it, but there was a question as to whether the state government should be involved in this at all because it might be a business concern. But there are limitations that are impacted by state statutes, and particularly when it comes to triage situations like I'm speaking on today. The access to a nanny share was impossible because nannies can only, by law, only care for one child from one family and one child from another family. And so that immediately wipes out your options for having quick access to childcare because it becomes illegal very, very quickly. And I would like to encourage you how to explore whether those statutes still hold in today's economy, in today's situation, in today's need of parents, and to figure out how we can support emergency childcare options, and of course, longer term sustainable options, but to help us access childcare when we need it most, which is when our really like a failing system proves again that it is shutting down and that it's not going to be sustainable again. So how do we take care of those interim periods between the time where one daycare closes and another daycare opens for the people who need it the most? And particularly for children, like I said, again, 0 to 5 years old. So I'm happy to host any questions. Thank you for listening to my diatribe.
You're welcome. Any questions from the committee? Representative Sedlak, if you know when you hear this.
Yep.
Perfect. Cut up. All right. Any other questions? Okay, I will call on you to make the motion the appropriate time. Any other questions? Seeing none. Thank you very much again, Ms. Sedlak, for being here and sharing
Thank you
that.
very
I
much.
have a feeling you're gonna get a bill draft out of it here in a second.
Great.
Before that, Mr. Caldwell, welcome. You're standing between us and dinner, but I know you spent a lot of time and effort on this. And so, yeah, if you'd present some legislative research before we give you a lot more to do. Floor is yours.
Thank you, Mr. Chairman, members of the committee, Clayton Caldwell, Legislative Service Office. And I've written a very brief memo on some of the strategies that have been used in other states to incentivize childcare services. And tonight, what I want to do is just very briefly explain the contents of this memo, and then I can stand for any questions that you might have. So to get started, some of the strategies that have been used in other states to incentivize childcare services include, one, improving the benefits and compensation of childcare staff. Two, the creation of state and employer agreements so that they can share the costs of childcare, which is incurred by eligible employees. Then three, the provision of programmatic benefits or zoning and land use statutes that can support family childcare providers, or in other words, childcare providers operating out of their own homes. As for the state of Wyoming, our state has actually passed legislation on this topic, particularly one bill that was introduced by the Joint Labor, Health, and Social Services Committee in 2006. And this was the Quality Child Care Act, and it included multiple provisions. And under that statute, the Y Quality Counts program provides grants and scholarship opportunities to early childhood educators and childcare providers. And speaking on the prevalence or the relevance of these kinds of programs in the state of Wyoming, roughly 34% of the state is in a childcare desert. And what's more, childcare deserts tend to be more prevalent in rural and low-income areas. And families that work non-traditional hours or might work on the weekends are going to be more likely to struggle to find childcare services that actually fit their schedules. Now, that's a very brief summary of the contents of this memo, but I would be happy to.
In the past couple of years dealing with childcare services, did you dig into any of that? I should remember if some of those passed, but I don't. Has that changed anything? And is that something you researched?
Ms. Caldwell.
Mr. Chairman, Representative Hornock, a couple of points that I can say in response to that is, one, in the 2024 budget session, we had passed legislation on this topic. Specifically, it was a bill that ensures that the provision of childcare is considered a residential use of property if it meets certain requirements. So that would be one such example. Also, the 2006 legislation has been amended a few times, and it is under more recent amendments that the Y Quality Counts program exists. Also on page 3 of my memo, I do mention a few other examples of how Wyoming is addressing some of these issues. One would be a program that's run by the University of Wyoming and a few partner organizations. That would be the last paragraph of page 3. So just to be very brief, I think those are a few examples that I can provide for you at this time.
Thank you, Mr. Chairman. So that legislation that was passed in the last budget session, that actually hasn't gone into effect yet. It goes into effect in a real soon, in a month or two. So we don't really know the results then of passing that bill. Is that correct?
Mr. Chairman, Representative Hornock, that is correct. It is recent legislation. Speaking on the older legislation, what I can say, because I reached out to the Department of Family Services and they were able to tell me that the funding that is provided to the Y Quality Counts program is allocated to grant recipients. And what's more, it does seem that they are able to use that funding for that purpose. So I can at least say that the grant funding is being used for that purpose, to provide training and educational opportunities. An additional detail that I can provide is that the Y Quality Counts program was recently supplemented with ARPA funding. However, applicants to the Y Quality Counts program are required to meet ARPA eligibility requirements in order to receive that funding. And for that reason, most of the applicants do not.
Else from anyone in the room? Yeah. Yeah. Oh, you just jump in. You don't have to apologize.
Thank you, Chair. I also wanted to emphasize, as we've been talking about this, we want to explore ways as these moms have shared that, you know, it's been tricky, but we also really want to make sure that it is still a safe situation. So working closely with DFS to, you know, if that is the road you want to go down, we really want to make sure we're working closely with them so that that safety piece is still really looked at closely, because we know those regulations are in place for a reason and don't want to kind of go off the rails and make things super crazy so that we're having wild packed houses of multiple kids that are, yeah. Anyway, just want to emphasize that.
Okay.
Chairman's house.
Right, no further public comment on CNE. So committee, at this point, if you have any thoughts for like actual legislation to be drafted, we can do that. If you just want some research to move the ball in the field, we can do that too. Representative Ward.
Thank you, Mr. Chairman. I move that we draft legislation to repeal the requirement that nannies can have only 2 households, expanding it to either 5, 3, whatever the committee is amenable to. 6, 10.
Well, if you want to throw out a number, you want to say 5 to be safe right now?
5.
5. Okay, is there a second?
Second.
Seconded by, is that Representative Penn? Okay, well, Alice, any questions on that draft before we take a vote? All those in favor of having that drafted, please say aye.
Aye.
Opposed, say no. That will be drafted for our next meeting for discussion. And maybe if there's some more information on the topic as well, that you can find or that the department could find for us on historical reasons why it was put in at 2. Senator Barlow, floor is yours.
He voted.
Oh, you voted aye. Great. On the record, we all voted aye. Oh, I didn't vote because that's the committee chair, but. All right, other thoughts? Representative Trujillo.
Thank you, Mr. Chair. I would just like more information for home daycares, not just the nanny piece on the regulations. I had 3 home daycares on my street close, and all due to regulations and paperwork from the government. So I'd like more information as to what are these regulations that
We
are.
were provided the rules and the regs, but if there is a way to kind of focus that down on when people reach out to you and say, hey, we're not doing this anymore, is there a certain regulation you hear over and over? Are there multiple? I don't know if you have that with you now or if you've done any kind of surveying. If there's one that catches 50% of our issues, we'd certainly be happy to hear for it now. But otherwise, certainly some further research into delving into the regulations that continue to be in question. Go ahead.
Sure. Thank you, Mr. Chairman. We did do just a quick survey of our licensors who they are the ones that receive notification when programs are closing, and they know why, right? And so we surveyed our licensors, and the why behind the closures from what we could see was really individuals would move, individuals would retire, individuals wanted to work outside of their home. It was not financially feasible for them to have childcare within their home. So really kind of more of the burnout of what we were talking about. But certainly we are in the process of putting an exit survey together for providers when they close to try to drill down a little bit more into that specific data. We can ask questions about any specific regulations that are a barrier to them. And certainly Representative Trujillo, if you have examples, we are happy to look further into those as well.
Thank you. And I'll get the examples from the 3 that closed, but it was really paperwork
Mr.
from the
Chair.
government.
I mean, have you had complaints on owners' paperwork and surveying and checking, or go ahead?
Mr. Chairman, yes, going back to the carbon copy issue, right? So that's really where we've put intentionality towards streamlining and modernizing our processes so that that paperwork is not so onerous. So hopefully by the spring of next year, we won't be seeing that nearly as much.
But I think we'd still like some review if there are, with this exit survey, any information by our next meeting, we'd be happy to hear. Representative Penn.
Thank you, Mr. Chairman. So the things that I've been hearing from the daycares in my area is staffing ratios, the number of training hours required, and the fact that 50% of them have to be done in person is very burdensome. Also, if they're I think this is applicable if they are providing food or taking state money.
They are surrounding 7 states on if those are similar requirements. If you could get that type of data or have LSO, just, I mean, it's one thing if we're wildly outside the bounds of where everybody else is, but if this is the marketplace, thoughts? While your mic's on.
Yes, thank you, Mr. Chairman. Thank you, Representative Penn. That's helpful direction. In regards to staffing ratios, that is some of the work that the Harvard Growth Lab has been looking into in regards to where we sit nationally. It is very fair to say that we sit within the median of the staffing ratios. They have a really cool infographic that I'd be happy to provide you that shows where Wyoming sits. And then it shows where we're at with other states and whether other states are within that median as well. And I think for the vast majority, there's a couple of age groups that's really shown that we need to take a look at. But for the vast majority of the age groups, we show in the median or even a little less stringent from a regulatory perspective. And then in regards to the training requirement and the in-person training, that's something that we will look into, and I think that we should. And then the sanitation issue that you brought up, that is part of the block grant, is having that health and sanitation. So we work closely with the Department of Ag to really try to be in as much alignment as possible in regards to the sanitation. And so we're partnering with them really closely, but certainly I'll take back I'll take back your comments to them as well.
Thank you. One more thing that I know has been brought up, and you brought up the staffing issues that are associated with this. You may be able to take 60 kids, but you only have enough staff to handle 40. And I have been told that a big issue that they're coming up against is the great deal of upfront costs and effort that it takes to hire someone in order to be then, they finally get all their background checks, their fingerprinting, their certifications, whatever is required. The new employee starts, spends a week, figures out it's not for them, and they quit. And so is there possibly a way that we could allow a grace period or a temporary permit or something like that for a staff member to come in and train, even without maybe having every single one of those pieces in place before they can even step foot in that situation?
If there is a last session that allows daycares in as being a residential use of property, it's up to 10 children. Do you think that that will have a positive effect on the child care deserts that we're experiencing?
Information education, but good luck. Go ahead, Mr. Connor.
Thank you, Mr. Chairman. That's a great question, Representative Hornock. And what I would direct you towards is some of the information that LSO provided in regards to zoning for home providers. They provided examples of other states where there have been less restrictions from a zoning perspective, not just a covenants perspective, but a zoning perspective for home providers. And I think that I think they're still measuring that impact. But I will say that outside of our rules, which just say you need to comply with local zoning and ordinances, right? That's what our rules speak to. We do hear that there are areas where zoning is difficult. There has to be petitions from the neighborhood to be able to start up a childcare program, and then you have to apply to the zoning board to be able to get approval. So that's a lengthy kind of sub process in itself that we know is apparent in some places. Again, it's community specific. But certainly, I think a look into, zoning and what's required of childcare programs isn't a bad thing to take a look at.
Okay, other ideas, topics, research requests? Yes, Representative Yen.
Mr. Chairman, so maybe the task force was made a little bit too heavy, but I do think that it'd be worthwhile to get more business community input and having them lead on what they believe is the issue with the elasticity with the supply side, not just what we've discussed here. If it's good with the chairman, I think it'd be worthwhile to have at least a subcommittee of maybe one or two legislators from the committee get together with Mr. Durrell and a bunch of other business leaders to talk about it.
Are you clarify what you're asking so I can respond appropriately would be great, Representative Yen. Are you asking us to try to create a subcommittee? Or a task force or ask management council?
No, Mr. Chairman, I'm not asking for a task force, just an informal group, just to chat and have conversations.
Crossing any boundaries and seeing if there's some research that could be provided to this committee. Is that fair for now? And if we need something more formalized at our Pinedale meeting, we'll direct something more formalized.
Great.
Okay. All right, any other research bill drafts? Not seeing any yet. You don't want to resurrect any of your former bills rather than VN?
Not at this time.
Okay. Well, any other general public comment come before us tonight? Seeing none, let me make sure committee 8:30 tomorrow morning still, I guess our agenda says we're starting at 8:30, so that's when we're starting. With that, we will adjourn for the day. Have a great Monday evening in lovely Star Valley, Wyoming. Although the rain